Well, so good morning, everyone. This is the meeting of the MOAT Committee, Market Access Oversight and Transparency Committee, and so it's a pleasure to have everyone here. Just to, I should let Colleen do this, but just to alert people, we're going to have the MOAT meeting first, and that's going to go from 9:30 to 11, and then at 11 o'clock is going to be the CDT meeting, which will follow immediately therefrom. So we encourage everyone who can to stick around for both committee meetings. We have both a full agenda and like an awesome agenda this morning. So we have like some really meaty issues for us to cover in the MOAT committee. One is on ambulance utilization and payment rates, which is something that has vexed us a few times over the years. And so I'm looking forward to coming back to it. The second presentation is on drug prices, which I don't know, has vexed us approximately every meeting we've had for the past 10 years. So it's really a really big deal. And then I believe we'll be coming back to the administrative complexity. I don't see it on this page. David, is that am I missing something, or did it get squeezed out for the others?
We're going to have to reschedule that presentation.
Okay, we were going to have it, but it's going to be rescheduled, which is good because we're going to need the time for the other ones as well. So that's what we have on tap today. Let me, before diving in, let me turn it over to David and Colleen for any introductory announcements or anything.
No, I would just welcome, we have our MOAT committee members here today, Chair Cutler and Commissioner Mastrogiovanni. We're also joined by HPC Board Chair Deb DeVoe, Commissioner Berwick, and Commissioner Cohen, and Commissioner Blakeney. So we have a full house today. And that's it for intros, and you can take it away.
Well, Commissioner, I'll just dive right in and introduce our first topic. As you said, we have two research presentations this morning, and they are both definitely meaty and in the weeds, but really interesting and exciting. So we're really proud to be able to present this new research today. So the first research presentation that we have is on ambulance use and payment in Massachusetts. And just by way of introduction, before I turn it over to Diana Sanchez, who is going to lead this presentation and was the lead researcher on this work. Why was this a topic that we decided to spend some time digging into? Well, I think there's a couple of major reasons. One, ground ambulance, is an essential component of a well-functioning healthcare system. Timely access to emergency transport can literally mean the difference between life and death, and so an important part of the healthcare system to consider. Secondly, we know that, like all other parts of the healthcare system, this sector is really challenged right now by workforce challenges. And the result of some of these workforce challenges means longer wait times for transport among facilities, being able to move patients from appropriate setting to appropriate setting. And that can create kind of a logjam throughout the system. And so a very timely sector that is being challenged right now. And I think that the third major relevance to the HPC's agenda for action that we laid out at the last board meeting is around this issue of surprise billing. We have long advocated at the Health Policy Commission for state policies to address the issues of surprise billing and protect patients from balanced bills in the case of utilizing out-of-network providers. While there has not yet been state action here in Massachusetts, there was federal action a few years ago in the No Surprises Act that did seek to put some protections and payment methods in place for out-of-network surprise situations. However, that federal law exempted ground ambulance, so they were not able to address ground ambulance, which is of particular interest because we do see in the data that there are the potential for many out-of-network ambulance rides that could result and a balanced bill to the patient. The federal law established a task force to try to dig further into this issue that, to my knowledge, has not even yet met. And so really this issue is back before the states to think about how they might address ground ambulance out of network billing situations, of what protections and payment rates might be most appropriate. So to kind of build towards some of these big policy conversations, we wanted to just start with a primer of understanding the landscape of ground ambulance in Massachusetts. Where are different companies being used? How is it being financed? What is the variation in payments for ground ambulance visits, both within Massachusetts, but then comparing Massachusetts to the country? And so really the goal of this presentation is to really kind of lay that foundation and an understanding of a sector of healthcare that often is not a particular focus for the Health Policy Commission, but is extremely relevant to our work. So with that, I am happy to turn it over to our Senior Research Associate, Dan Sanchez, to walk through this presentation.
Great, thank you so much, Director Seltz. Good morning, Commissioners. I'm pleased to be sharing with you this research on emergency ground ambulance use and payment rates here in the Commonwealth. See here, outline of our presentation. So for the next 20 or 25 minutes or so, I'll be walking through ground ambulance in general, with an introduction, and then going into some findings from an analysis in our APCD, where we characterize the ground ambulance landscape generally here in Massachusetts, and then dive deeper into commercial payments for these services. And finally, we'll close out with other payment approaches to ground ambulance, including how Medicare and Medicaid pay for ground ambulance services, as well as other states such as Maine and Connecticut. Next slide, please. Okay, and starting off with a bird's eye view, emergency medical services, or EMS, is defined by the Office of EMS here in Massachusetts as the pre-hospital assessment, treatment, and other services used in responding to an emergency or provided during an emergency. EMS is typically provided by ambulance services, and each local jurisdiction in the Commonwealth must designate a primary ambulance service. Ambulance services may be publicly or privately owned, as we'll talk a little bit more about as we continue in the presentation. But as such, can be thought of as bridging both the public safety and the healthcare systems, and in some ways reflect characteristics inherent to both, as we try to show in this Venn diagram on this slide. Next slide, please. So ambulance services may be broadly categorized into three distinct categories as defined by the Office of EMS here in Massachusetts. Those three categories are basic life support, or BLS, advanced life support, or ALS, and critical care transport. And they differ in the level of intervention provided. And as a note, BLS and ALS transports may be further subdivided into emergency and non-emergency categories, depending on the context of the transport. Next slide, please. One issue that has been known to arise in relation to ambulance use is out-of-network or surprise billing, often because, and especially in the context of an emergency, patients do not have the ability to choose a provider in their insurer's network. And in the case of a surprise bill, a patient may be expected to pay the difference between what the ambulance provider charges and what was paid by their patient's insurer. And as we've noted, out-of-network and surprise billing in Massachusetts has been an area of continued interest for the HPC. Next slide, please. As Director Seltz noted, the discussion around surprise billing has been active at the federal level, particularly with the passage of the No Surprises Act at the beginning of 2022, and with the notable exclusion of ground ambulance services from those billing protections. And that's maybe significant here in Massachusetts because in a previous publication, the HPC reported that nearly half of ambulance encounters in 2017 resulted in at least one out-of-network claim, as you can see in a diagram from that publication on the right-hand side of this slide. And in the absence of these protections, potential surprise billing for ground ambulance transports continues to impact commercially insured residents, as evidenced by recent news coverage. Next slide, please. However, in addition to the potential for surprise billing, differences in the structure of EMS or what type of ambulance service responds to 911 calls between individual cities and towns may additionally contribute to the existence of higher rates for emergency ambulance services. And so this publication seeks to explore this additional dimension of emergency ground ambulance use by examining patient rates for transports by the type of ambulance service that responded, particularly as it relates to commercially insured patients. Next slide, please. And so the broad aim, just to reiterate, is to develop a more comprehensive understanding of the emergency ground ambulance landscape here in the Commonwealth. And in doing that, we are looking at ground ambulance transports regardless of out-of-network status and focusing particularly on utilization rates, as well as charges and total paid amounts for BLS emergency and ALS-1 emergency services. And then we also look at the use of municipally operated versus privately owned ambulance services. And to the extent possible in this publication, we compare commercial ground ambulance payment rates to those of other payers and states. And we are doing this using our all-payer claims database with data from 2017 to 2020. And as a note, we focus particularly on one-way ambulance encounters with Massachusetts-based ambulance companies. Next slide, please. Great, and so those are our introductory slides, and now moving to some of our top line results, but with a note first about ambulance staffing here in Massachusetts. And just to note here that there are strict regulations regarding staffing of ambulances here in the Commonwealth, although some were relaxed at the beginning of the COVID pandemic to ensure sufficient staffing during the public health emergency. And to note, one change was recently made permanent earlier this past January with regards to BLS transports. And finally, an additional note here on this slide is on the right-hand side about the presence, as we know, of EMS staffing challenges, which have been reported here in Massachusetts as well as nationally. And nationally, factors that may contribute to, particularly to EMS staffing turnover, include factors such as wages, work-life balance, and burnout, with a note that other states are considering different policy actions to address these challenges. Next slide, please. Great. And now jumping into the results from our data. So in between 2017 and 2019, we saw that there are between 33 and 38 ambulance transports per year for 1,000 commercially insured members. However, we do see fewer transports in 2020, potentially related to the onset of the COVID pandemic. Next slide, please. And zoning in on 2019 in particular, we see that most ambulance transports were ALS-1 emergency and BLS emergency transports, the two leftmost bars in this exhibit. Most of these transports, about 87%, were transports from the scene of an accident or acute event or a residence to a hospital, while the other four types of ambulance transports, the four rightmost bars, or more likely to be transfers between hospitals. Next slide, please. So those were some top lines on ambulance transports in general, but now we'll be looking a little bit more into ambulance service ownership structure. And broadly, in Massachusetts, ambulance services are provided by both publicly and privately owned entities. Publicly owned ambulance services are generally municipal entities and are commonly associated with fire departments. However, some are standalone non-fire entities that are categorized as a third service, such as Boston EMS and Fall River EMS. And in addition, 2 services in the Commonwealth are operated by their town's police department. On the other hand, privately owned ambulance services can either be not-for-profit, perhaps associated with a hospital or with colleges or universities, or for-profit standalone entities. And as a note, publicly owned and privately owned ambulance services may differ in their mix and their sources of funding. While both may receive payment from MassHealth, Medicare, or commercial insurers for ambulance transports, additional funding sources between the 2 types may vary. For example, publicly owned ambulance services may be additionally funded by municipal budgets or by subscription services, while privately owned ambulance services may be additionally funded by contracts with municipalities or healthcare facilities. And in addition, many privately owned services obtain significant revenue from non-emergency transports. And finally, just to expand a little bit on that point about private ambulance services contracting with municipalities, that's related to the requirement that municipalities designate a primary ambulance service. A municipality, for a variety of reasons, may choose to contract with a private ambulance service to respond to all 911 calls in their city or town. And while terms may vary and it is not known how many ambulance services are contracted with municipalities at a given time, it is a notable component of the ambulance landscape. And so in the following exhibits, we'll be referring to publicly owned ambulance services as municipal services and privately owned services as private services. Next slide, please. And so now focusing just on 2019 and ALS-1 emergency and BLS emergency transports, we see that private and municipal services accounted for similar shares of these transports among commercially insured patients, about half and half. Next slide, please. Great, and so now moving towards what we've learned in terms of commercial payment for ambulance services. And continuing to focus on 2019, we see that for both ALS emergency and BLS emergency transports, most of the payment, or here as median paid amount, for these encounters is for the service component, with mileage being a relatively small portion. Next slide, please. However, when we further look into these median charges and median paid amounts by the type of ambulance service that responded, we saw that payers paid municipal ambulance services roughly double what they paid private ambulance services per transport. Next slide, please. And focusing just particularly on ALS emergency transports and comparing median paid amounts by municipal and private services, we see that most payments, and in this case excluding mileage for these encounters to private services, were between $500 and $1,000, indicated by the orange bars, while payments to municipal services were between $750 and $2,500, indicated by the blue bars. Next slide, please. And when we compare rates in 2017 versus 2020, we see something of a rightward shift. where in 2017, 17% of payments to municipal services in particular exceeded $2,000. However, by 2020, that proportion doubled to 34%. Next slide, please. And zooming out and looking at changes between 2017 and 2020, we see that overall, median paid amounts have grown the fastest for ambulance encounters with municipal ambulance services, regardless of type of transport. And those are indicated by the dark orange and the lighter orange lines in this exhibit. Next slide, please. And when we continue to look at median paid amounts for municipal versus private services, but this time by payer, we do see that all payers, and these are 5 major payers, paid substantially more to municipal than to private ambulance services, with significant variation across payers. And we do note here that differences in payment within each commercial insurer may be related to intra-payer differences and rate of contracting with private versus municipal services. Next slide, please. And finally, when we look municipality by municipality, we do see that in 2019, for ALS emergency encounters, there's a wide variation in median paid amounts by municipality. And we note that this is due to both variation in EMS structure, as well as the mix of commercial payers. Next slide, please. Great, and so those were our main results from our APCD analysis. And then for this last portion, I'll be moving into other payment approaches for ground ambulance use. And so here in this slide, we're able to compare our commercial median paid amount from our APCD analysis to rates for ground ambulance transport for MassHealth and for Medicare. And we see that commercial paid amounts were far higher than MassHealth and Medicare rates of payment in 2019 and 2020. However, we would like to note that both MassHealth and Medicare payment rates increased in 2022. Next slide, please. However, when we look at other states, we do see that Maine and Connecticut, our neighbors, have both addressed ambulance billing reimbursement, although in slightly different ways. In Maine, in 2021, their legislature enacted a law that requires payers to reimburse out-of-network ambulance service providers for emergency services according to certain guidelines, as noted in that sub-bullet here, unless the payer and the service provider agree otherwise. And in addition, this law requires payers to offer a standard contract to all ambulance service providers willing to participate in their provider network. And this legislation, from our understanding, was an outgrowth of some prior work that Maine has done in regards to EMS payment. And on the other hand, in Connecticut, Connecticut has for a long time maintained the rates for which ambulance services are paid through their Office of EMS and annually adjust the rates. In addition, their Office of EMS publishes these maximum allowable rates for individual EMS organizations each year. And on the next slide, with that information that Connecticut makes available, we're able to compare their maximum allowable rate in 2021 to our Massachusetts median rate in 2020 for commercially insured patients. And we see that in Massachusetts, our median rate is higher for both ALS emergency and BLS emergency transports compared to that Connecticut maximum allowable rate. Next slide, please. And finally, based on a paper that was published actually just a couple of weeks ago in Health Affairs, looking at ground ambulance billing and prices by ownership structure nationally, we're able to compare our Massachusetts average allowed amount in 2017 to the national average allowed amount between 2016 and 2017. And we see that average paid amounts for ALS emergency transports in particular via publicly owned ambulance services in Massachusetts were twice as high as average paid amounts for similar transports nationally among commercially insured patients. Next slide, please. And just 2 additional slides to conclude our presentation here. So just to summarize, in this presentation, we saw that most ambulance encounters here in Massachusetts in 2019 were ALS emergency and BLS emergency transports. And about half of these encounters were serviced by privately owned ambulance services, with the other half serviced by municipally owned services. And for both ALS and BLS emergency encounters, paid amounts varied by more than 3-fold across commercial payers. And we saw that commercial payers paid municipally owned services about twice as much per transport as they paid privately owned services. And finally, for 2019, we saw that median commercial payments in Massachusetts were 2.7 and 4.6 times higher than Medicare and MassHealth rates, respectively, and were also higher than maximum allowable rates in Connecticut. Next slide, please. And finally, for this last slide, just to note some areas that we've identified for future potential research and monitoring. Those include investigating the impact of the COVID pandemic on emergency ground ambulance use and rates, especially into 2021 and beyond. Following the work and recommendations of the Federal Advisory Committee on Ground Ambulance and Patient Billing, which was named this past fall to address, the exclusion of ground ambulances from the Federal No Surprises Act. And finally, to follow along with progress in other states on addressing emergency ground ambulance billing and rates. So just following what continues to happen in Maine and Connecticut. So thank you all so much for your attention. Please, happy to answer any questions. Thank you.
That was super interesting. And I know there are going to be a bunch of comments. Don, I see your hand up. I'm going to jump in at some point. Others, please raise your virtual hand as well. Don, let me turn it over to you.
Would you like to go first, David? I'm happy to follow you.
No, go ahead. Go ahead.
Wow, what a superb report, Dana. Thank you so much. So clear. I have 3 initial questions. The first is, why are public payments higher than commercial? What do you believe to be the underlying driver? Second, do you have a view yet or a lens on out-of-pocket implications for individuals from these payment rates? And third, as I think you surely know, many cities, Denver famously, Seattle, and others, plus a lot of European municipalities have created hybrids of their ambulance services in which the objective is not to take the patient to the hospital. The ambulance is deployed and the hospital is the last choice. They try to find other ways to meet needs in the patient's home through triage to alternative settings. I don't know if those experiments are well underway in Massachusetts, but they're very important paramedical assets. And I don't know if how that impacts our analysis or whether we have any data on that. That's a lot. That's a mouthful of questions, but thanks again for a great report.
Great, thank you. Yes, and happy to answer those questions to the best of my ability. First, with regards to why rates for transports among municipal services are higher than those for private services, we don't have the clearest picture of that, although we do think that it may be related to differences in payer contracting with private versus municipal services. It may be that payers are less likely to contract with municipal services, for example. In terms of out-of-pocket consideration, that is not something that we touch on in this chart pack, although we do know that for in-network ambulance services, out-of-pocket costs and cost sharing differs depending on the patient's insurer. And that's something that we can look into a little bit more. And finally, that's an interesting point on the idea of hybrid approaches to ambulance treatment and use, emergency treatment, pre-hospital treatment. That's not something that we've looked into particularly for this chart pack, but something we can definitely look into going forward.
Yeah, on that third point, Diane, I'll just, I don't know how Denver or Seattle or other progressive cities have dealt with the financing of these community paramedicine components of their ambulance services, but they're really exciting to study. You might do some benchmarking.
Thank you.
Deb, let me call on you.
Can I just say something to the addition to the first question of Dr.
Yeah,
Wood?
absolutely, David. Yeah.
It's, as to why the municipal rates are higher, we talked to a few payers and it seems complicated, and maybe some of the other folks on the call, like Kate, could help with this answer, but it seems to be related to the out-of-network situation where the payers said they didn't feel they had any leverage over the municipal rates, and that's partly why those payment rates are about where the charges are, and versus the private companies where they did this dance a while ago with sending the bill directly to the patient and this complicated leverage to avoid the out-of-network scenario. But that didn't seem to work for the municipals, where they had no incentive to contract to accept the private rates that the payers were offering. I don't know if that clarifies it at all. It was very complicated, but maybe Kate, do you have anything to add to that?
No, not at this time. I don't think so. Thanks, David.
Deb?
Yes, thanks so much. Terrific report. Such an important topic for us, and I'm really glad to see the recent data. Do we have any understanding of how the experience in Maine and Connecticut has affected access? I, am mindful of your comments around, Diana's comments around the continuing challenges around staffing, and I wonder whether we have any insight as to whether this has caused issues in those states.
Yeah, that's a great question. Thank you. That is not something that we have looked into for either Maine or for Connecticut, but certainly something that we can take a look at. Yeah, but I know in Maine, part of the reason why they've been so active in EMS is that because it is so rural, I believe they're seeing fewer ambulance services operating in general, and so that's been having impacts in their own state. But yeah, something we can look into more.
So let me jump in, and then Marty, I'll turn to you after that. I have a bunch of different comments relating. This was a superb presentation. My first comment is, I think if Congress was unwilling to tackle the no ambulances in the No Surprises Act, we should do so as a state. The reason they couldn't was because of politics of various things, and that shouldn't. This is not a service, almost by definition, where people are going to shop around. So there's just no rationale at all for calling an ambulance, being in a medical emergency, and then not knowing how much it's going to cost, or finding out later on that it was an unaffordable thing. So I think we ought to propose to the legislature maybe one, if we think there's one way to solve it, or two or three ways to solve it, but encourage the legislature to act, just because there's just absolutely no way this can happen. And to that, along those lines, I think some things, some facts that will help us, not so much the median payment, but the high end of the outliers. How many people have to pay just ungodly amounts of money for an ambulance just because nobody has just settled this issue yet. And so we ought to go about settling it. I do think along the lines of where Don Berwick's question was going, I think we ought to try and look a little bit more at the cost structure of the ambulance industry. So I've tried to do a little bit of looking, like if it was really profitable, what you'd expect to see like private equity and stuff trying to get involved in it, so do we see a lot of entry into it? And as best I can tell, there is some of that. There's some sort of private equity, particularly with air ambulances, because they get to charge a ton. And so you do see some. However, there was not nearly as much as I had guessed there would be if it was like a super profitable thing, the way that there is for some kinds of, imaging facilities and so on. So I'm wondering kind of what the cost structure looks like, if we can get anything on what the cost structure looks like, so we can get a sense as to whether this is really profitable and someone's making a ton of money off ambulances, which we don't want, or whether this is really just what it costs today to run a modern ambulance system, and so therefore we have to go with that. And so this may be a little more for David Auerbach in terms of next steps, but I just sort of want to understand a little more about not just the rates but the profitability. So let me sort of toss those two thoughts back to you. I understand, Diana, they may not be. You should give comments, but those comments are both broader than just specifically what was in the presentation here.
Yes, thank you. I'm sorry, I was waiting to see if David wanted to step in, but just wanted to note that that is an excellent point. In our chart pack, we do discuss a bit about the cost associated with providing ambulance services. In this project, we were able to get access to CHIA's ambulance cost reports, and they collect those cost reports from private ambulance services that receive more than $100,000 per year in MassHealth revenue. And they do, these providers, a select number of private providers, do report costs with providing services, ranging from employee compensation to vehicle expenses, and they enumerate those. And maybe that is one way that we can look a little bit more into the cost structure and the costs associated with these services. But David, you can add anything else.
That's right. I think we could learn some more there. And also, she has a slide that we didn't show today, but it's in the full chart pack, that the GAO did a study in 2012. And this is I wish they would update it. And they found that at that time, on average, the Medicare payment was just about enough to cover average cost, which was, $450 or so per transport. And since then, some of the folks we've talked to have said, well, the Medicare payment has not kept up with costs, and that sounds reasonable. But trying to understand where those average costs really are, I think would also be helpful, and we could probably learn some more about that. I agree.
Thanks. I have Marty next in line and then Ron after Marty.
Thanks, David. I absolutely agree with you that I think this is something that requires attention. I have just sort of two questions. One, I know a lot of municipalities sort of move to private contracting. Is that a trend that's continuing in the state? And two, do we know how municipalities what their contracting with insurers looks like? Is it done town by town, or is this something that fire chiefs get together, the association negotiates on their behalf? Because I think that may play here. And lastly, to David's comment about equity plays, I think, if I'm correct, AMR, American Medical Response, was a private equity play, and they seem to have disappeared in the state. So I don't know if that tells us something.
Thank you for those questions. So in terms of if there's any trends in terms of the number of municipalities that contract with private services, that's not something that we have insight to. It is not known how many private ambulance services are contracted with municipalities at a given time. If only there were a list that existed, but that's unfortunately not something that we have insight into. In terms of your second point about how municipality contracting with insurers works, from our understanding, and anybody else can jump in as necessary. Our understanding is that it's generally on a municipality by municipality basis. We're not aware about groups of fire chiefs or something, as you had noted, deciding payer contracting. And finally, that's an interesting point about AMR. We'll look into it a little bit more, but yeah, that is a ambulance service that I believe is particularly active in the Worcester area. So thank you.
Ron?
Thank you, Diana. Excellent job. I agree with everything that's been said to date, and when we look at surprise billing and just the cost of these services, it's something we really need to look at. Something else that we can't really ignore, and it was mentioned, is staffing. And are we seeing a significant difference in how individuals are being paid within the private organizations versus public organizations? I know I looked at data several years ago, and folks working at the ambulance services, they are not getting paid a significant rate when you look at what they go through in order to qualify, and then the services they're providing. And is that something we should be looking at as well? Because we can correct all the pricing we want. If we don't have folks working for ambulance services, it's a problem. And how much work have we done on the staffing issue, and what's behind the staffing issues? Is it rates? Is it the COVID? Has it really changed since prior to COVID versus today? It would be interesting to know, and we should be looking at that as well. Thank you very much.
Thank you. Yes, and in terms of compensation for our staff, depending on private versus public organizations, that's not something that we looked into for this publication, but something that we can definitely investigate further, especially how it relates to EMS staffing shortages. Thank you.
But Ron, you didn't say it, but I would be super leery of an argument which is we need to pay ambulances more so they can pay workers more. That it, like all good monopolists, once they have a monopoly, they're going to pay as little as they can, and if you pay them more, they'll pocket it as profits. So
I agree completely.
I'm not particularly open to that argument unless someone has got some better reason than that.
If you look at the margins, which is something that we need to look at, the financials, and the question becomes, given the fact that we need to increase staffing, should the state, I don't know how that's done, can they require that they meet certain standards in terms of staffing? And maybe that's something we need to look at, because right now, I do know the private firms are having problems with staffing, and that could be life-threatening, so that's something that we just can't ignore. But I agree, I'm not suggesting that the firms increase their margins or maintain their margins in order to pay staff.
I'll just jump in with a couple of thoughts as well. I absolutely agree, Ron, and we are seeing the challenges playing out right now today in our state in terms of the staffing challenges and the resulting delays in transports particularly, from a hospital to, say, a skilled nursing facility. And I want to recognize someone who joined us in this meeting today, Amy Bianco from EOHHS, who's the director of health policy and has worked a lot over the last few years in terms of the state's COVID response. And I know that that has been an area that there has been a lot of thought and attention put into about how the state can help unclog the system, and help get patients moved in a timely way through the system. So absolutely top of mind. I think, this presentation, we're going to release this as a chart pack. You commissioners have all raised really interesting questions. And I think part of the goal of releasing this chart pack is to kind of spark that dialogue more broadly in our healthcare community. And I expect and hope that we will hear from, more ambulance companies. We'll hear from more health plans who, after looking and seeing some of this data, may be able to come meet with us and provide even greater insights into what is driving some of the trends and the variation that we're presenting here. And then finally, just to say, to Don's point around, more innovative ways of using paramedics, both in paramedicine or mobile integrated health. There are absolutely really interesting experiments happening in Massachusetts on that. But oftentimes, I just spoke to a hospital CEO who was so jazzed about this program where, they're using the paramedics to be able to divert patients and not bring them to the hospital, not bring them to the emergency department. And he was lamenting to me that unfortunately, the finances of that, he ends up hurting his own bottom line because he is helping to support that additional patient care and not receiving the revenue of having an admission into his hospital. And so he was actually lamenting that he's generating savings to the health plan, but not actually generating savings to his bottom line. So I think when we think about those models, we have to think about what is the financing model that makes it the incentives for the providers who want to do the right thing, that they're actually going to be financially rewarded for that. And that speaks to, alternative payment methods and global budgets and things like that. So just a lot of interesting threads to pull on here. And that's, not even to mention the surprise billing aspect of this and patients getting, kind of stuck in the middle. So, really wanted to kind of make this presentation and this chart pack kind of be our opening foray into this area. But Commissioner Berwick, I see you have your hand raised.
Yeah, thanks, David. I'm really kind of depressed and excited by your anecdote about the CEO you're talking about. I think in a way that's the point. I think this report's fantastic. We're going to learn a lot, but this is a chance to lean into the future. And I'm pretty convinced these community paramedicine ideas, especially when hospital beds are overflowing, when we don't staffing shortages, that's important. So as I know you will, let's not just do a report on the current or past situation, but lean into the future, which may have to do with a more expansive view of payment and reimbursement systems and possibilities. There's a lot of potential here, I think. So thanks, David.
That's great. Absolutely. Amy?
Thanks, everyone, and good morning. Good to see all of you. As David said, this is my first committee meeting. Wonderful to be here with all of you. Amy Bianco, Director of Health Policy and Strategic Initiatives here at EHS. And David, just in response to, and Don, your comments as well about kind of looking into the future, I think from the state's perspective, we acknowledge the balance of kind of looking to the immediate needs of ensuring that transport remains available in those emergency situations and ensuring that we have the workforce and the supply to address those situations and ensure that that is not a barrier to discharge, throughput, et cetera, hospital capacity. However, are also focused on the future, as Don, you pointed out, in things such as mobile integrated health. And so I did just want to point out that, I believe it was this past fall of 2022, the Department of Public Health significantly decreased the previously associated fees associated with standing up mobile integrated health. And so I say that as that is something that we are trying to get the word out. So in your conversations with providers around this, or just in the general conversation here, I think the Commonwealth is incredibly interested in breaking down any barriers that would be in the way of promoting mobile integrated health, because of course we see this as kind of addressing many of our goals here of one, ensuring that folks can be supported in the care, addressing our current hospital constraints, et cetera. We hope to move forward with that, in also hoping to address and support the workforce that needs to come along with that. The other thing I would say too, and just again on the workforce piece, I think that is one of the primary challenges around all of this, is that we're also looking at ways that we can be innovative in our approaches as it relates to workforce, and thinking about ways in which we can, of course, all in with patient safety and quality at the forefront of all of this, think of other ways to transport patients and to utilize what is right now limited resources in the ways that they most need to be. So one example of this is that we did provide an opportunity for nursing facilities who have transport vehicles to receive reimbursement from MassHealth to be able to transport in non-emergency situations to dialysis appointments, other appointments, utilizing that nursing facility van to free up additional resources. So I'd be interested too, moving forward in the committee's perspective and looking at other states or just in general, thinking about ways in which we can be creative and innovative, again, all within the confines of ensuring that patient safety and quality remains paramount, but ways in which that we can think outside the box here to ensure that needs across the board are met, and that we also are continuing to look to the future of ways in which we can utilize models like mobile integrated health moving forward.
So I just want to pick up on a couple of the last comments because I thought they were excellent, and they're helping to crystallize things for me. There are a couple sorts of issues here. One is kind of operational efficiency of the ambulance system, and I think those are rich and complicated issues that we need to study and so on. In my mind, in the back of my mind, the issue of no surprises is simpler because it's on the patient end. It's on, out of all of this, what does the patient get charged, and not how do you get the right payment system in place for things like that and so on. And so I wonder whether we should think about proceeding on two tracks. One is with respect to the operations of the ambulance system and understanding the relative efficiency of municipal versus private ambulances and the nature of the ambulances and so on. And then second is making recommendations to the legislature about how we could address, how we could bring ambulances into the no surprises sort of legislation that didn't happen federally.
I think that sounds great, Commissioner Cutler, and we're excited to continue this work. I think let's maybe shift to the next presentation because we have another pretty rich research presentation here. And I'll go ahead and tee this up really quickly. So I think the relevance of pharmaceutical pricing to our mission, I think, is quite obvious. This has been a topic and focus for the commission since our inception in trying to understand all of the different drivers of healthcare spending in Massachusetts, and this is a really important component of that. It is also a component that is often very opaque and complicated, and understanding kind of what is the true right price net of rebates and being able to compare those is very well protected and often very confidential. And so we really wanted to try to bring some more transparency to this topic, and really excited to turn this over to Celia Siegel, who will go through this presentation. But this is brand new research from the HPC, and I think quite groundbreaking in its own right. And so without further ado, take it away, Celia.
Good morning. I am not allowed to turn on my video, so if whoever is host would turn on my video. Thank you. Hi, nice to see you all. My name is Celia Siegel. I'm the Associate Director of Pharmaceutical Pricing and Policy here. Thank you, Director Seltz, for the introduction, and I'm very much looking forward to this conversation today. My goal in this presentation is to take a closer look at retail pharmaceutical spending trends in Massachusetts and better understand those drugs that have high spending. And second, to understand by how much prices vary for those drugs across US payers and in comparison to international payers. I doubt many here will be surprised by our findings that US payers typically pay much more for drugs that we evaluated in comparison to certain other countries. And while not surprising, it can be helpful to view specific examples and by how much the prices vary. And we'll do that today. Perhaps we found it more instructive in this presentation to understand instances when that was not true, when that the US spent more on drugs than other countries, or that certain payers in the US did not spend more on drugs than in other countries. And my ultimate goal here today is for this presentation to lead to a discussion on the different policy levers that we use currently to address pharmaceutical prices in the US and how those policy tools can be updated or added to in a state context regarding our drug spending. I'm going to start by presenting on retail pharmaceutical spending trends. Some of this work might look familiar. It was in our fall, some of it was in our fall cost trends report. Then I will go into methods on how we selected retail drugs for analysis and how we assess drug prices among different payers. These methods will help in some of our policy discussion later. I'll present the results of our analyses on comparative prices, and we'll end on a policy discussion. Next slide. For many years, we've issued policy recommendations for the Commonwealth to take action to constrain pharmaceutical prices, and in particular, strengthen our role at the HPC. Currently, key participants in the pharmaceutical sector, manufacturers, pharmacy benefit managers especially, are not specifically listed under our oversight responsibility, unless under very narrow circumstances if Medicaid is unable to negotiate with a drug company. This is a more concise version of our most recent policy recommendation on this slide to expand our oversight of these different stakeholders in the pharmaceutical sector and to improve our transparency on prices. Next slide. These policy recommendations that we've issued throughout the past several years are rooted in trends we've witnessed in pharmaceutical spending. Since 2014, net spending growth on retail pharmaceuticals has almost always been above the benchmark. This is most notable starting in 2014 and 15, when, as you will recall, the hepatitis C drugs were newly approved. In the most recent years reported, net spending on retail pharmaceuticals grew by nearly 8%. And that's just in a retail setting. We know from cost trends work that outpatient drugs have been identified as one of the key contributors to outpatient spending growth. But my focus here today is on retail drugs, those drugs dispensed at the pharmacy counter. I'll pause here to explain the difference in gross spending and net spending. Gross spending, that navy blue bar, is what is paid by the health plan or pharmacy benefit manager so that patients can retrieve their prescriptions at the pharmacy counter. For many branded drugs, after prescriptions are dispensed to patients, the PBM and/or health plan will receive rebates from the drug manufacturer, which act to reduce prices for those drugs post hoc. Net spending is what is actually spent on drugs after the health plan receives those discounts and rebates. CHIA collects total rebates received by Massachusetts payers to inform their net spending numbers. They also collect rebate information at a very high level, rebates received for all branded drugs combined and for all generic drugs combined. Next slide. Branded drugs represent a growing share of retail drug spending for commercial payers in Massachusetts. From 2017 to 20, that navy blue bar, you'll notice the percentage of claims for branded drugs remained relatively flat at around 13 and 14%, whereas the amount we spent on branded drugs, that yellow bar, has trended upward from 75% of total drug spending in 2017 to 79% in 2020. This could be due to increasing launch prices of new drugs. It could also be, as experts at the CBO suggest, that while generics have helped to temper the effect of rising launch prices in recent decades, the effect has lessened in recent years and may be less strong going forward since generic dispensing rates have become so high. In this case, generics have almost stabilized at over 85% of drug claims. Next slide.
Can I just ask, does that include Medicare, Part D, or is this only commercial?
This is just commercial. Next slide. Oh, we're here. There is some evidence in the commercial claims, I'll clarify, of rising costs of branded drugs on average, driven mainly by the highest cost drug claims becoming more expensive. The interquartile range has really not changed a huge amount over the time frame presented, and the median has largely stayed the same, but the highest cost drugs are getting more expensive, and that is drawing up the average. Next slide. Finally, we know that out-of-pocket costs have grown for patients for pharmaceuticals, and this has especially been true for certain patients with chronic conditions who need high-cost drugs, which can sometimes interfere with managing and treating disease. Next slide. In this new analysis, our goal was to understand which drugs were driving spending and the degree of price variation between US payers and international payers. Next slide. A lot of the prior work, as I mentioned, was previously presented in the cost trends report to set context on spending trends. As part of our analysis on prescription drug spending, we wanted to better understand which drugs had a high level of spending in Massachusetts and how drug prices for the highest spending drugs varied across US payers and international payers. Our goals in this research, as stated here, are to contribute to the evidence base on pharmaceutical prices, variation between payers in the US and internationally, and the impact of pharmaceutical prices on healthcare spending in Massachusetts. Second, to understand the policy factors that contribute to variation in prices, particularly in Massachusetts. And third, to inform policy discussions regarding options to better align pharmaceutical pricing with value for Massachusetts residents. Next slide. To select our list of drugs for a price comparison, we started by identifying 100 retail drugs with the highest spending at Medicaid, Medicare, and Massachusetts commercial payers. Of those top 100 drugs in terms of spending, if a drug had an annual cost per claim greater than $10,000 or was on the list of the top 25 highest spending drugs for that payer, for 2 out of 3 payer types, these are our criteria, we included it on our list. We used these 2 criteria because we thought it was important to look at drugs that were high spending or had both high spending and a high cost per claim, because much of the current policy discussion centers on those 2 criteria for understanding growth in drug spending. If we just looked at drugs with a high cost per claim, we might not see some of the drugs that treat more prevalent conditions, such as the diabetes therapies here. But if we only looked at the highest spending drugs, we might miss some of those drugs that were still high spending and notably had a high cost per claim, but were for less prevalent conditions. So this is the approach in which we tried to find the right balance. We ultimately compared the monthly prices of these 18 drugs at US payers and international payers. Next slide. The next step was assessing prices for those 18 drugs. And as you might already know, it's not so straightforward because prices for both public and private payers are all kept very confidential. Since Medicare Part D is structured as an independent marketplace and commercial plans manage the prescription drug benefit for Medicare enrollees, commercial prices in Medicare are often grouped together. Health plans typically negotiate their prices for drugs through pharmacy benefit managers. And we obtained drug-specific net price estimates from SSR Health, which is a leading analytic firm frequently cited in drug price analyses. They estimate commercial and Medicare rebates for each drug by looking at publicly reported revenue statements and matching it to estimated utilization to calculate the difference between what ought to be the gross revenue for the drug based on the list price and the actual revenue generated from the drug due to rebates. Next slide. We wanted to include the VA's price as a comparator because they are often cited in policy discussions as an example of competitive price negotiations for a government payer. To understand their prices, it actually takes kind of cross-checking sources, including the publicly available fee schedule listing drug prices for the 4 largest federal purchasers, and cross-checking that with the VA's formulary and publicly available price contracts on the VA's procurement website. The big 4 agencies include the VA, Department of Defense, Public Health Service, and Coast Guard, and they generally pay lower prices than other direct federal purchasers because of a statutory cap on the prices they pay. But we know that through their negotiations, the VA and the DoD actually pay less than what is publicly available in a fee schedule. This graph is from a report from the CBO showing the differences between the prices at the Big Four, which are publicly available, and the VA's prices. Since we were particularly interested in pricing at the VA, if a drug was not on the VA's formulary, we excluded it from our analysis. Next slide. Medicaid drug prices are based on two statutory rebates that are calculated by CMS confidentially as a percentage off of the average manufacturer price, or AMP. The AMP is the average price that drug manufacturers charge wholesalers to purchase their drug for distribution to pharmacies. The first statutory rebate is known as the base rebate, or the Medicaid best price rebate colloquially. Drug manufacturers that sell drugs through the Medicaid program, have to sell drugs to the Medicaid program at the best price, or with a base rebate of 23.1% off of the AMP, whichever results in the lowest price. The second rebate is what we'll call the inflation-based rebate, and we'll talk a lot about that today. Drug manufacturers must pay an additional rebate to Medicaid if the price of the drug increases faster than inflation since it was lodged. This graph here is just a mock example of how the two statutory rebates required work together to establish drug prices for Medicaid. We wanted to include it as illustrative because it's how we calculated Medicaid drug prices. If a drug was launched in 2009 at an annual price of around $9,000 and the manufacturer increased its price by 2021 to $24,000, then the manufacturer has to first pay Medicaid an inflation-based rebate that would be equal to the difference between the current price of the drug and the price of the drug if the price grew at the rate of inflation. Then on top of that, the drug manufacturer has to pay an additional rebate of 23.1% off of the average price. Inflation-based rebates are especially relevant right now because they recently went into effect this quarter for Medicare as a result of the Inflation Reduction Act. If a drug price grows faster than inflation, drug makers will need to provide an inflation-based rebate back to Medicare. And it is unclear what that will mean for drug prices if manufacturers will continue to increase prices year over year. If they do not, it is not clear what that will mean for Medicaid specifically, because in some cases, the base rebate plus the inflation-based rebate can actually make the price of a drug go down for certain drugs with high price increases at Medicaid. Next slide. Finally, most other countries negotiate nationally their drug prices based on their own regulatory regimes. Several countries make their prices publicly available. These prices are akin to list prices in the US and may be subject to additional confidential discounts or rebates. So the public prices really represent a maximum being paid in those countries. We considered including other countries that are frequently compared to the US, Germany or Japan, for example. Our biggest obstacle was not having someone who could speak those languages and look through those websites for publicly available information. Next slide. Well, I'll move into the results of our analysis. Next slide. The next two slides, you'll see two different cuts of this data. In this graph, you see the percentage discount for those 18 top spending drugs off of the US list price. Big picture, and unsurprisingly, US commercial plans and Medicare plans have the highest estimated prices relative to all other payers, followed by direct federal purchasers, then Medicaid. Australia, Canada, and France are all lowest and have kind of a comparable median. One big challenge was that we felt it was important to present price comparisons between US and international comparators for drugs that have full data. The UK was missing a lot of data because many of the drugs had confidential agreements in place. Only 9 drugs had publicly available prices. So this first visual includes all 18 drugs that we included in our analysis, but we excluded the UK due to inadequate data. You might also notice here that the direct federal purchasers were missing a lot of drug prices. I left in the ends here. That is because the VA excluded many of these high spending drugs from their formulary and preferred a competitor drug instead. We decided to leave in the direct federal purchasers bar here for illustrative purposes, but I do want to flag that this distribution of discounts that you see here is for a more limited subset of drugs than the distribution seen for other payers. You'll notice in this distribution, some drugs have a very low discount off of the list price. For US commercial, that first bar there, for US commercial and Medicare plans, some of the cancer drugs we reviewed have very minimal rebates, offering a net price that represents only 95% of the list price. On the bottom end of that first bar there, you'll notice that some of the drugs have a net price that have a significant discount off of the list price. The lowest part of the distribution is a drug for diabetes that's an estimated 17% of the price it's listed for. Drugs for very severe conditions that don't necessarily have a therapeutically similar alternative, like different types of cancers, often have very low discounts, whereas drugs in very competitive drug classes, for instance, diabetes or asthma, often have very high discounts. Next slide. This is the second version of this graph with 9 common drugs across these 6 payers. These 9 drugs are the only drugs for which we had full data across all of the payers. The pattern is similar, although in comparison to the prior graph, there's a steeper drop to the price distribution for Medicaid and international comparators, and Medicaid's range is closer to those international comparators. Many of the drugs that have full data across these payers are older, and it's become increasingly common in the UK, especially, to negotiate confidentially, which is why we don't have as full data for some of the newer drugs on our list. But the fact that these drugs in this mix of 9 drugs are older is why there's a starker drop for Medicaid, and is why their prices are more comparable to other countries. Older drugs, especially these older drugs, have higher rebates due to inflation-based rebates, and we'll talk more about that in a few minutes. Next slide. For the majority of drugs we reviewed as part of our list, commercial and Medicare net prices were at least 2 times more expensive than prices in comparator countries. In general, 13 of the 18 drugs reviewed followed this general pattern within US, where US commercial payers and Medicare paid the most, followed by direct federal purchasers, Medicaid, and then international payers. This is an example of Jakafi, if I'm saying that correctly, an oral oncology drug used to treat bone marrow cancer and certain blood disorders. Jakafi was on our list of top 100 spending drugs at commercial plans and Medicare, with an average cost per prescription over $10,000. So this drug met the high cost per claim, high spend criteria I talked about earlier. We estimated that commercial payers paid a net price over $12,000 per month on average. Federal purchasers paid slightly less. International Medicaid and international comparators paid approximately 1/3 of what commercial payers do. And that's kind of what we'd all expect based on what we know. Next slide. Here's an example of a psychiatry drug that treats schizophrenia and schizoaffective disorder. The price for a month's supply of this drug is very different than the price for a month's supply of the previous cancer drug. But per our criteria, it's on the list of top 25 for spending at Medicare and Medicaid, which is why we included it. As you can see, the pattern is similar. And also, there's no publicly available price in the UK because they've negotiated a confidential discount. Next slide. But there are exceptions to this general rule of commercial plans in the US paying the most, followed by federal purchasers, Medicaid, and international comparators. There are some older branded drugs that have very high Medicaid rebates, to the point where their prices are lower than international comparators. This is largely due to inflation-based rebates. Humira was launched in 2002 as one of the first biologics. Humira has the company who makes Humira has raised the list price of the drug each year at a rate far past normal inflation. As a result, Humira has a very high statutory inflation-based rebate through the Medicaid program. And there are other examples of this on our list of drugs, especially for the older drugs, such as Enbrel and Revlimid. Next slide. In this slide, you see the list price of Trulicity, which is on our list of highest spending drugs for treating patients with diabetes. The list price available for Trulicity for federal purchasers is $557, but the VA has excluded Trulicity from its formulary and instead lists a therapeutic alternative within the same drug class, Ozempic, which they've negotiated to a far lower price. In some cases, it doesn't really matter what's listed on the fee schedule. It's more important to look at the price of the within class drug included on the formulary to get a sense on how the negotiations went. Commercial payers, most notably Medicare, frequently use formulary exclusion as a tactic to negotiate competitively, but it can impact access to certain drugs. Medicaid cannot and has to cover every drug if a drug manufacturer complies with the mandatory rebates. Next slide. Next slide. We'll move into a policy discussion now. It is widely commented that the US pays more than other countries for prescription drugs. This study found the same results on average across 18 retail drugs selected per our criteria with high costs. US payers and Medicare payers, on average, commercial and Medicare payers on average paid the most for drugs pretty consistently. For other government payers, certain drugs may be less expensive on average than other countries due to policy interventions, such as inflation-based rebates at Medicaid or less restrictive policies that enable the VA to negotiate. There are several possible factors that could explain why pharmaceutical spending has exceeded the benchmark in most years, including high launch prices. We saw in the first half of this presentation that the high cost drugs are getting more expensive, even though the distribution of most drug prices in the interquartile range are mostly staying the same. This has been validated by at least one study of launch prices that demonstrated major increases in the last decade in launch prices. Drug price inflation is also a key driver of spending growth. We saw that in the example presented with Humira. You can get a sense from just looking at the price at Medicaid, how high its rate of price inflation has been above normal inflation since it was first launched in 2002. And there are lots of examples of that in our list of drugs as well. The CBO did an analysis when scoring the Inflation Reduction Act on kind of how many products had high rates of inflation, and the finding is listed here. And finally, we didn't spend that much time on this in our research, but while the impact of generics over the last 2 decades has helped to temper spending increases, there is concerns from experts that generics have reached the saturation point and that the impact of biosimilars is uncertain because they're so new and they're different from generics and have varied effect in kind of in tempering drug spending increases. Next slide. So where do we go from here? There have been 3 policy discussions that have been especially relevant nationally and in Massachusetts. The first is addressing price increases. And the important national context is that due to the Inflation Reduction Act, Medicare will now start this quarter, or in a couple of years, but based on inflation starting this quarter, to receive an inflation-based rebate, much of like that which is in effect for Medicaid. There is significant uncertainty about how this inflation-based rebate will impact commercial payers and Medicaid departments. Many think that if the inflation-based rebate works to control the rate of price inflation, drug manufacturers will instead launch drugs at higher prices. For Medicaid departments, if drug manufacturers do not increase prices, they may not receive as much revenue from inflation-based rebates, which and base rebates, which are based off of that average manufacturer price, which can in some cases, as we saw in the previous example, make prices for certain drugs go down. So there is some important national context that's important to consider in Massachusetts. For 2 sessions in a row, former Governor Baker introduced legislation that would introduce inflation-based rebates in Massachusetts. So there has been some policy discussions locally on this point specifically. Second, there is evidence that prices, especially for the highest cost therapies, are going up. Many other states are wrestling with many of these same issues and have instituted new oversight boards to bring transparency to high cost drugs and issue policy recommendations. In Massachusetts, the HPC supports our Medicaid department in their supplemental rebate negotiations. But in the past several years in our cost trends reports, we have made the case to broaden our oversight beyond the Medicaid program. And there have been several legislative proposals on the table to do just that. And finally, as you saw, it requires a lot of assumptions and calculations and corralling of proprietary and public data sources to actually estimate the net spending on a drug or group of drugs, which we need to understand cost drivers at different payers. Collecting more data for transparency and reporting has been a key part of the legislative debate in the past few sessions. And so I will end there and open it up for discussion.
Oh my.
Oh, I should preview, and we have some more research coming out. This was kind of part 1 of the presentation. Part 2 is kind of looking more so at other countries and the comparison between the US policies and other countries and policies in other countries. We're also going to be doing a deeper dive into outpatient spending. And then finally, we'll be looking at out-of-pocket costs for certain high-cost drugs and policy options to address affordability. And now I'm really done.
So who wants to start off our discussion? There was a lot of stuff there. Well, people are gathering their thoughts. Celia, let me start off with a couple of thoughts. So first, thank you. That was amazing. One thing you said that was encouraging to me is that a lot of the growth is in a small number of drugs. And so that suggests that it's not a, sort of widespread thing that the Commonwealth would need to address, 50 different drugs and, that each of the top 100 drugs would require something, but that actually a lot of the growth is a relatively small number. So therefore, if the Commonwealth wanted to take a look at choose, maybe that might be a calculation to add, if we chose the top 5 or top 10 drugs, like how much of the total increase in drug spending above inflation or something would we explain by that? So that's one. That's one fact I think that was helpful. That might be helpful. The other thing that came to my mind, but I'll just say this, but I think it's a really bad idea, is, for some of these conditions where Medicaid gets much, much lower prices than everyone else, than commercial insurers, you almost want to say, gosh, we should have like a special carve-in where people with that condition can go into Medicaid. And then we can take advantage of the huge savings, maybe let the private insurer buy into Medicaid or something for that patient. But I mean, that's just such a horrible idea because of the segmentation of the care, but it's still like for some of these patients, it would just be enormously valuable, and for the for the insurance plans that they're in, and for the patients out of pocket, and for the Commonwealth, and so on. So I think the first of those is probably somewhat more relevant in terms of thinking about where we would want to go, but the second one just sort of jumps up. Don?
Yeah, thanks, Celia. Boy, you make a complicated area a little more accessible, and thanks for your expertise. I have a really dumb question. I keep struggling with it, but my brain keeps losing track, which is about rebates and out of pocket. When we see a fall in price due to rebate, what should be our assumption in terms of what's happening to the patient at the point of sale, are they experiencing a lower price because of the rebate, or is that money going elsewhere? Or is there some way to think about that proportionately?
It's very difficult to know because it's very dependent on the contract between the payer and the pharmacy benefit manager, and whether they've negotiated rebates at the point of sale as part of their contract, which passes through savings to patients, or whether health plans are kind of holding on to rebate savings, which theoretically lead to their drug spending overall. And so we don't know. It's been there's a lot of work out there about how rebates are based off of, or out-of-pocket spending is typically based off of the list price of the drug and not the rebated price of the drug, which in many cases could lead to higher out-of-pocket costs for patients, even if there's a big reduction in price due to a rebate.
David Seltz, what are our next steps on the pharma issue? We spoke at the end of the ambulances about some possible next steps there. What are our next steps here?
Well, this is a top priority in our action agenda this year as laid out in the last board meeting. In particular, continue to advocate for the legislative changes at the state level that would expand the HPC's oversight and expand not just HPC, but SHIA as well, our ability to collect information and data to provide more transparency and oversight, and to really bring the pharmaceutical sector, not just the manufacturers, but pharmacy benefit managers, underneath the umbrella of accountability under cost containment. And that will require legislative action. And so working with our friends in the legislature and the Healy-Driscoll administration, I think, is a top priority to see those changes be enacted into law. Many other states have moved forward on policies to directly address pharmaceutical pricing and transparency. We are, as a state, behind many of those other states, but that also provides us an opportunity to learn from those other states. And I think we have put forward some really strong recommendations. So that's number one. And I think the second is the continued research agenda that Celia laid out, where, you know, as we continue to advocate for legislative change, can we use all of the data and information at our disposal to create more policy insights into this field? And as Celia said, this, you know, really does require kind of going through with a fine-tooth comb websites, you know, data books, and we're going to, you know, continue to work with our experts to expand on that. So I think those are the two avenues that I would highlight for our next steps.
Barbara?
Thank you, David, and thank you for allowing a visitor to your committee to participate. I'd like to swing back to something Don said about what's the impact on the consumer. And as we think about going forward, if that can be the lens that we use to look at the effectiveness of the policy changes or the policy proposals that we're offering, it strikes me that that is perhaps the best ultimate standard to use. I have no interest in a rebate going back to the drug company. I have no interest in any policy that we might recommend or might be adopted that takes away from what the consumer needs. They're on a shoestring. They're hanging on by the tip of their fingers. And anything that we can do from a policy or legislative perspective to advocate for them getting the break as opposed to anybody else's, I think needs to be our central barometer, if you will. Thank you.
Thank you, Barbara. I completely agree. And I think the survey studies that we've discussed at previous meetings that show an increasing proportion of Massachusetts residents who are not getting the care that they need due to the cost of care. We see that number increasing. We see the number of patients who say that they can't afford to fill their prescriptions, that are splitting pills. This is a real consumer patient care issue. And so I think you're absolutely right to refocus us on that lens. Thank you.
Both of the topics today have been real consumer payment issues at the time of use, not just through premiums, but at the time of use. So they're really something that I think we need to keep addressing. I know we have an agenda for the year. I think at our coming board meetings, we should sort of take a look at where we are on them and make sure we're on track to do whatever it is we think we ought to be doing there.
That sounds great.
By the bells ringing outside, it sounds somewhere around 11 o'clock. So I think, and this has exhausted our agenda for this meeting. So thanks, everyone. And let me turn the microphone back over to HPC Central.
Great. Well, thank you, commissioners, and thank you, Commissioner Cutler, for a great meeting and a great discussion. Lots more to come on this. We're now going to shift right into our Care Delivery Transformation Committee meeting. We do have a special guest joining us for the first part of this meeting. So if you need to step away and take a break, absolutely do so. But we're going to continue to move forward. And I think as we pull up the slides for the next meeting, I am happy to turn it over to the chair of this committee, Barbara Blakeney.
Thank you, David, and thank you for a great earlier meeting. You're going to notice that my screen is doing crazy things, and so I'm only going to stay on visually until we get this set up, and then I will not expose you to the distraction. And so welcome to the CDT meeting, the Care Delivery and Transportation Group. And we have, as David hinted, we have a really great agenda, going to go deeply into a couple of topics. And so I want to get right to it by calling the meeting to order and asking Colleen to lead us through our minutes and a vote on our minutes.
Absolutely, I'm happy to do so. We could show the motion on the slide. We have a motion here. Do I have, a motion on the table from one of the CDT committee members?
So moved.
And a second?
Second.
Excellent. By roll call vote, we'll start with you, Madam Chair Blakeney.
Approved.
Commissioner Berwick.
Approved.
Commissioner Cohen.
Approved.
And I would like to welcome and also ask her to abstain, acting under Secretary Karen Sung, who's joining us for the first time today for her first committee meeting. Welcome, Karen.
Thanks so much, Colleen. Abstain.
Thank you so much. We also have non-voting member Chair Deb DeVoe of the HPC board joining us here today. Thank you so much. And back to you, Madam Chair.
Well, thank you. That was quick and easy. Appreciate that. Our guest presentation today, and I'm going to invite Kelly to do the introductions because she is raving about Ryan and the work that he's done and is very excited to be able to present him to us. So Kelly, please do the honors.
I will be happy to do that, but I'm actually going to invite Catherine Harrison to do that, but just because she is the architect of this particular presentation. But let me just say, just to orient folks, as all of you know, one of the important roles that the HPC plays is as a certifier of accountable care organizations in the Commonwealth. And through this process, we actually have an incredible opportunity both to learn what ACOs are doing around quality and cost, and also in some cases to influence where they're focusing their energies. So we have a really interesting agenda today that kind of covers both of those angles. And in order to kind of give you a little bit of orientation, I do want to turn it over to Catherine Harrison, who is the Deputy Director of our Healthcare Transformation and Innovation team, and also one of the early architects of the ACO certification program, who continues to be involved in shaping it. So I appreciate the introduction, Commissioner Blakeney, but I'm going to turn it over to the expert and let Catherine kick us off. Thank you.
All right, thanks, Kelly. That's quite an introduction. Hello, commissioners. Nice to see you all. So the meeting that we've organized for today, as Kelly has alluded to, really is an opportunity to talk deeply about what's happening with Massachusetts ACOs and where this important vehicle for care delivery and payment reform is going over the next few years. And we'd like to look at this from a couple of different angles. So first, from the vantage point of MassHealth, and then through the HPC's key lever of our ACO certification program. As you all know, the HPC has and continues to promote advancement of the ACO model as a way for providers to deliver and coordinate care under a set of incentives that are aligned with delivering value. And one of the ways that we do this, that we promote this advancement of this model, is through ACO certification, which since 2017 has been the primary pathway through which the HPC has set expectations for capabilities that every ACO should possess and deploy across every population they serve under a risk contract, whether commercial, Medicare, or MassHealth. We are continuing to evolve and try to advance our ACO certification standards. And a little later in this meeting, my colleagues, Christy Helskell and Mike Stanek, would like to share a proposal with you for an updated certification requirement related to ACO's work to advance health equity. And that work is one of the HPC's 2023 action agenda items that Executive Director Seltz discussed with you at the board meeting in January, and that we also reviewed with the Advisory Council last week, just for those keeping track at home. But before we get to that, for the past several years, MassHealth has been blazing trails in providing care and services to its members under ACOs. In 2018, 17 ACOs began serving MassHealth members under a total cost of care payment model with responsibility for the overall health and costs of a population of enrolled members. Drawing on lessons learned from those first 5-year ACO contracts and backed by the groundbreaking new 1115 demonstration waiver, MassHealth is launching its 2023 ACO program in just a few short months. This new program features some exciting developments, including but not limited to a health equity incentive program and a capitation payment for primary care services. And these innovations really broadcast where and how the ACO model is evolving. And because MassHealth requires all of its contracted ACOs to also achieve HPC ACO certification, we at the staff level spend a lot of time thinking about how these two programs can complement each other, reinforce each other, and collectively advance the ACO model in the state. So we thought that taking a closer look today at MassHealth's program would be a great prelude to discussing the updates that I mentioned that we are proposing to the HPC ACO certification program. So with that, I would be very honored to introduce our guest, Ryan Schwartz. Ryan is an internal medicine and pediatrics physician. He is currently chief of the Office of Payment and Care Delivery Innovation at MassHealth. And he previously served as the clinical lead for the Massachusetts COVID-19 Response Command Center. So Ryan obviously hasn't had a night's sleep in 3 years. Prior to his time in state government, Ryan worked with multiple governments and ministries of health as a technical advisor to the World Bank, and he practices clinically at MGH's Chelsea Health Center. So without further ado, Ryan, welcome, and we're delighted to have you.
Thanks so much, Catherine. Commissioners, David, thanks for the opportunity to be here today. It's really a pleasure to share some of the work that we're doing and would value your feedback. There's a lot going on in 23 and the next couple of years, and we're really looking forward to working more closely with the HPC as we pursue some of these new initiatives. So please, as we go through today, interrupt with questions. Happy to take this in whatever direction is most helpful. That being said, we'll start, if you could advance to the next slide, please. We'll start with just a little bit of stage setting for where we are in going into year 6 of the MassHealth ACO program, where we've kind of been over the last 5 years, and then in particular, what we're anticipating starting on April 1st, where we are launching the new program. So to back up, as Catherine mentioned, beginning in 2018, under our last 1115 waiver, MassHealth went through a fairly substantial, probably the largest since the ACA for the state, care delivery transformation. Over about 850,000 members were transitioned initially into ACOs in March of 2018. So we're just coming up on 5 years, and in the last year, 2022, we re-procured the program, which we'll talk more about shortly. So what have we learned, and what's been the experience of ACOs over the last several years? Just to hit a few quick highlights to level set with everybody, and then we'll also talk a little bit about the structure of the ACO program and the ACO models. So currently, we are at about 1.2 million members in ACOs, and we're anticipating about the same number starting in April under the next program. What we've seen over the last 5 years, and I'll caveat all of this by saying COVID complicates a lot of these results, but we are still very optimistic about these results. Even despite COVID, we've seen a substantial increase in primary care engagement among our ACO book of business. Over a 10% increase in primary care engagement among ACO members relative to non-ACO members. And that's also despite the challenges with primary care engagement during COVID. So still a fairly substantial increase from our perspective. We've seen an optimistic view of the ability of ACOs to impact preventable acute utilization. Prior to the pandemic, we saw an 11% decline in preventable acute utilization among ACOs. During the pandemic, those numbers become very difficult to discuss. And I'll probably actually ask David Auerbach to answer any questions about utilization during the pandemic, because HPC's analyses have been very helpful in that regard. But we still have seen overall a optimistic signal towards generally over the last 5 years, ACOs continuing to impact preventable utilization. And coming out of the pandemic in the last year and a half, we've continued to be very optimistic about the numbers that we're seeing. In terms of clinical quality, we do have a standardized quality slate, across the ACO program, very much mirrors our MCO program, and has worked very closely with the HPC and the Quality Measure Alignment Task Force in Massachusetts to get that as close to some of the measures that other payers use. Generally speaking, when we look at our quality slate, we've seen substantial improvements in about 2/3 of the quality measures. During the current 5-year program, we have had a number of operational challenges with some of our quality measures, and we are adjusting that quality slate in the next program. We can talk a little bit more about that. But from our perspective, overall, we've seen generally very positive trends across ACOs on the clinical quality slate. Again, reinforcing in our minds that this program is having its intended impact early on in the course of the program to start to impact quality measures. As many of you are familiar with, the Community Partners program was launched in parallel with the ACO program. Community Partners are community-based organizations that focus in particular on behavioral health and long-term services and supports for some of our most complex members. To date, this program has now served over 180,000 of the most complicated MassHealth ACO members. And we've seen, I would say, two big things. One, we have learned a tremendous amount about the operationalization of this program. Many of you have followed. It had a rocky start. We had a lot of challenges with our community partner organizations. We had a lot of challenges at MassHealth. And we had a lot of challenges at the interface between MassHealth, our ACOs, and the community partner organizations. We have learned a huge amount in the last 5 years about the ways to run this program well, and some good lessons learned and areas for improvement as we move forward. And I would say, having watched the trajectory of that, we are in a much better place. But we will talk later very shortly about some additional improvements that we're making to the program in the next set of contracts to continue to refine the model to better serve our members. That being said, despite those challenges, the impact of this program has really been quite impressive. We've just included a few brief numbers here, but we've been very, very impressed with the ability of our community partner organizations to really meaningfully improve some of the outcome and process measures for this population. So just to call out a few, and these account for changes during the COVID pandemic. Despite the pandemic, we've seen over a 20% reduction in emergency department visits for community partners members, a 30% reduction in behavioral health admissions, and a 20% risk-adjusted total cost of care for these members over the last 5 years. So from our perspective, still a lot of room to continue to refine this model and work at the interface between ACOs and community partner organizations, but some very early optimistic results in terms of its ability to impact some of the key goals of the ACO program. Finally, our flexible services program, which many of you have followed. As a refresher, our flexible services program is a pilot program currently operated under CMS authority through the last 1115 that specifically targets nutrition and housing support services. We'll talk more about what we're doing with Flex moving forward, but for a variety of reasons, and in particular because of the delay in authority from under the Trump administration, this program was not initiated until January of 2020. Which, as many of you remember, shortly thereafter was an auspicious time for the world. So this was a difficult and challenging time to stand up a very broad and I'll say pretty bold and aspirational program. That being said, despite the challenges of standing this program up and trying to get ACOs to focus on this during the pandemic, we've still seen a really impressive early set of results. So just to hit a few numbers, Flex has now served over 20,000 members for both nutrition and housing support services through our ACOs. It is a pilot program, so it was not intended to be at scale in the first few years. So we see these numbers as very good in terms of what we were able to do, especially during the pandemic. And we've spent about $50 million on nutrition and housing support services through our ACOs that has been federally financed. Every flexible service program run by an ACO is necessarily different. So ACOs have discretion in the current set of contracts to design flexible services programs to meet the needs of their members that they feel will be most effective. Many ACOs use medically tailored meals for some of their diabetic patients. Other ACOs use food vouchers for some of their individuals experiencing food insecurity. And we have a whole slew of housing support services, from eviction prevention programs to case management and social workers working with members experiencing homelessness or at high risk of homelessness to help improve their housing situation. So it's hard to present single outcome measures across the flexible services program, given the difference in interventions. But just to name a few of the things that we've seen, for many of our programs targeted at diabetic members, we've seen substantial reductions in their hemoglobin A1C outcomes, and in fairly impressive ways. We've seen decreased total cost of care, decreased utilization, improved housing security, et cetera. So overall, a good start to a program that started during COVID, and we'll talk a little bit more about where that's going moving forward. Next slide, please. Excuse me. So this is the ecosystem as it will exist on April 1st, 2023. We're going to focus most of today's talk on the left side of this slide. So in current state, we actually have 3 models for our ACO program. For expediency purposes, we're not going to spend a whole lot of time on what we refer to as Model C. Model C ultimately was not, it was subscale, and we didn't feel it was effective, and so we will be discontinuing the program on March 31st. Happy to follow up on that, but for the purposes of getting through a lot of other material, we'll focus primarily on Model A and Model B in this talk, excuse me. So Model A, or also known as our accountable care partnership plans, these are our traditional Model A ACO programs. This is a health plan partner, partnering directly with the delivery system provider. Health plan handles the health plan functions. Delivery system is contracted to actually provide care. They have a PMPM capitated rate for their attributed members, and they take on full insurance risk. There's upside and downside as a part of this contract. Beginning on April 1st, we're anticipating about 880,000 members will be enrolled in Model A's. And the last slide of this presentation will give you the full list of ACOs that are starting on April 1st. So we'll come back to that. Our Model B program, this is our primary care ACO program. In this model, we as MassHealth serve effectively the health plan functions, and we contract directly with the health system provider. Members in Model B have access to the MassHealth Provider Network and the Massachusetts Behavioral Health Partnership for their behavioral health services. There is a more fee-for-service payment chassis. We'll talk a little bit more about this shortly. And has annual savings and losses reconciliation at the end of the year, retrospective to the annual total cost of care. Also has two-sided risk. There are different risk tracks for Model B. There's 3 risk tracks. And moving forward, we have 2 Model B ACOs, which we're anticipating about 350,000 members in the Model B program starting on April 1st. We will continue to operate our traditional MCO program and our traditional primary care clinician PCC program, which are more traditional managed care products. These programs, as time has gone on, have declined in their size and scope, which we see as an overall good thing. More members are being cared for in the value-based products in the ACO program. We're still anticipating about 150,000 members between the MCO program and the PCC program starting April 1st. Next slide, please. So there's a lot changing on April 1st. However, for the purposes of trying to get through this material, I'm going to hit on 4 high-level buckets that we think are some of the more exciting and innovative areas of policy and care delivery transformation moving forward. Happy to take questions on the other areas that we'll skip over, but we're going to focus on these 4 today. So just to hit them quickly, and then we'll go into more detail on each. First off, we are capitating primary care, and we'll talk more about the why and the what that looks like. But we believe that this will help us provide better care for our members. And importantly, through this program, we will be dramatically increasing investment in primary care rates relative to historic. Bucket 2, we are going to double down on our focus on clinical quality as a part of the ACO program and invest substantially in a health equity incentive program, which will hold providers financially accountable to closing disparities within their populations. Bucket 3, we are going to increase our expectations around health-related social needs services. So this is in particular our flexible services program, as well as our community supports program, which we'll talk a little bit more about. And bucket 4, as I previewed earlier, we are continuing the community partners program. We do believe that there are other areas for continued enhancements in the model here to better serve our members. And so we'll talk a little bit more about what those are. Next slide, please. Excuse me. So primary care capitation. So first off, why and what are we trying to do? And then we'll get into some of the details. In the current program, we have Model A and Model B. Model A is capitated. However, at the primary care level, in terms of what I as a clinician or my colleagues experience on a day-to-day basis, that is ultimately left up to the plans. The plans get a capitated rate, but much of our delivery system is still based on a fee-for-service chassis. We believe fundamentally that is juxtaposed to optimizing care for the members that we're serving, and are trying to slowly tip the delivery system more towards enabling providers the flexibility and the sustainable revenue that they need to provide what we think of as the right care in the right place at the right time. And frequently, just to be explicit, that is not a doctor's visit for 15 minutes. It's instead better behavioral health integration. It's team-based care. It's working with a social worker or a behavioral health clinician or a community health worker. Sometimes it's seeing me. Sometimes it's seeing one of my diabetes nurse educators. But in the traditional fee-for-service payment mechanism, which we currently have, we disincentivize and make much more difficult for provider systems to invest in this type of team-based integrated primary care. So starting on April 1st, all ACO practices, as a requirement of participating in the ACO, will receive a prospective risk-adjusted PMPM for the members that are attributed to their providers. The explicit goal here is to help shift the payment system across the market more towards capitation and start to enable providers to focus more on the care delivery transformation within their own practice that's necessary to actually start to do some of this team-based integrated primary care that we think will provide better care for our members. Point 2 here. Primary care, as you guys have said many times before, is historically underinvested in, and certainly at the Medicaid level, our rates are inadequate to what we would like to see our members be able to receive from our providers. So if we don't start to close that delta between what we think primary care needs to be spent and where we are currently, we're not going to be able to effectively support our providers or enable them the flexibility that they need to do the things that we're saying they should be doing in the capitation program. So the Baker administration committed to an increase in investment relative to historic primary care rates of about $115 million, and we have committed to that and budgeted that for the next 5 years. So easiest way to think about this is if you trend forward historic primary care rates in Medicaid and tap on top of that, about $115 million will be invested into practices participating in the ACO program and the subcapitation program specifically. This is also, as is probably obvious, but to be overt, this is a carrot to get practices to participate in the ACO program and also to feel comfortable participating in the capitation program. Capitation did not have a great track record in past decades. We believe that by operating this program within the construct of the ACO program, which is accountable to quality, which is accountable to member experience, and which is accountable to overall cost, we won't see the challenges that some capitation programs historically did experience, where it was all about a downward spiral and tamping down utilization and taking those cap dollars. All of our practices are still accountable to the same quality slate, and there is substantial upside that we will talk about shortly, attributed to those quality slate measures. So we hope that will prevent any challenges with capitation in the past. The last thing I'll say, which is important to be explicit, we as Medicaid are not going to be successful in transitioning the provider system to capitation on our own. There's good data to show that providers don't change their behavior until they are feeling on a day-to-day basis about 60 to 70% of their payer mix as capitation. We are 60 to 70% of no practices payer mix across the state. I work in a health center in Chelsea. I'm like one of the high Medicaid payer mixes, and I'm still at about 50, 55%, which means unless other payers are at the table with us, we will not be successful in this initiative. And it is very much our intention and hope that we will be able to further galvanize other payers to start to do similar payment mechanisms in the coming years. Next slide, please. So quality and health equity. So in the current program, we focus a lot on quality. As I mentioned, we have seen an overall, what we believe, early signs of good improvement in quality measures across our quality slate. I'm not going to spend a whole lot of time talking about the measures in those quality slate, but we've learned a lot about some measures that just haven't worked, and we will be changing some of the measures on that slate. Thank you also to the QMAT, which has been very helpful in terms of guiding this process. That being said, one of the other lessons that we learned was the way our contract was structured to incentivize quality over the last 5 years was a little bit too complex, and it was hard for providers to be able to look at the quality slate and say, if I do this, I will get this amount of dollars. It was all retrospective. Data lag and claims lag took a long time for providers to be able to see and feel and directly attribute improvements in their programs and the quality measures that they're tracking to what the dollars they were getting from Medicaid are. So we're simplifying that to be very, very high level today. It's going to be 0.75% of the TCOC that any ACO or MCO will be able to get. And it'll hopefully be easier for providers to be able to look at what they're doing on a day-to-day, month-to-month basis and say, we're improving here, we're going to get this amount of dollars, we can project that, budget for it, and anticipate it on the back end. That's, I would say, an incremental change that we're making, not something that is dramatic. but is important in terms of how we refine the program to make this more easily accessible and hopefully more broaden the uptake across the provider system. The second part of this slide is what we're more excited about. In our most recent 1115 authorization in September, we received authority to dramatically financially incentivize and hold provider systems accountable to closing health disparities across the Commonwealth. This is going to be operationalized in 2 pillars. Given that this talk is supposed to be about the ACO program, I'm only going to talk slightly about the hospital program here, but it is important because I want to emphasize that what our acute care hospitals feel from a financial incentive perspective will be very, very nearly identical to what our ACOs and MCOs feel. And that is intentional because we want the entirety of the provider system to feel the same incentives and to feel the same accountability, to explicitly incentivize them to work together in a way that is beneficial for everybody. So what is this going to look like? We are pegging even our clinical quality incentive and our health equity incentive, 0.75% TCOC for both. For the health equity incentives, given the infrastructure investments that provider systems will need to make to be able to start doing some of these things, we're adding some admin dollars. So it's about 70 million and 80 million annually, slight difference, but from a financial incentive, it is intended to be very similar. We are explicit there because we want provider systems to feel and understand that our emphasis is on both of these equally and that they should be investing in both equally. For health equity, what does this mean? So a part of the 1115 that we're very excited about and we feel is quite innovative and is now being looked at by multiple other states across the country is focusing in particular on building the capacity and infrastructure across the provider system to be able to measure disparities and then close those deltas within the attributed population. In order to do that, the first thing we need is data. So a substantial part of this program will be investing and forcing or financially incentivizing provider systems to make the investments in the infrastructure and the data backend that they need to collect, and they will be held accountable for race, ethnicity, language, disability, sexual orientation, and gender identity of all of their members. In parallel, MassHealth is making the commitment to doing the same on our extremely antiquated data and IT systems ourselves. And that is a very substantial and frankly, long overdue investment that we have been meaning to make. And this authority and doing so across the provider system will enable us to do so as well. So moving forward, starting actually in October for hospitals and on April 1st for ACOs and MCOs, all provider systems will be financially accountable to collecting these data and reporting these. And in order to do so, they have to build the systems to do so. And just to get very granular, that means new servers, that means new hard drives, that also means Epic overhauls and their EHR interface. And these things take a long time. So this program will start out as pay for reporting and invest and incentivize providers to be able to do this work, so that by years 2, 3, 4, and 5 of the program, we will start to transition that P for R into P for P, where they will be responsible for reporting stratified quality measures by these indices. We will start out with stratified reporting for REL and move eventually into DSOGI in a way that enables provider systems to focus on building the capacity to start out with reporting race, ethnicity, and language. And then as they're doing that in parallel, building the infrastructure and systems and workflows to collect disability, sexual orientation, and gender identity. These things are hard and they will take us a long time to be able to operationalize. And so the program is intentionally staged to do so in a staged way. Moving forward, provider systems will then be held accountable as a part of their health equity incentive to actually closing population-specific deltas within those indices. So they will be required to report the measures, and then they will be required to start to close some of those deltas across these measures within their own attributed population. Again, starts P for R, moves to P for P. The intention here, technically speaking, we only have authority for the next 5 years, but we are optimistic that our federal partners will enable us to continue this kind of work moving forward after year 5, and certainly that would be the intention. Next slide, please. Bucket 3 is health-related social needs. So we talked a little bit, excuse me, at the beginning of the talk on our work with a flexible services program. Flexible services program focuses on nutrition and housing support services. We've only run the program for 3 years now, and when we went back to CMS for our 1115 negotiations, what we really asked for was for them to extend our authority to enable us to continue to test the program. We're very optimistic, but we did not necessarily anticipate that our quote-unquote results or outcomes to date would substantiate a broadening of this authority. However, I will say that we were very pleased to find a very open and aligned audience with our federal partners. And in addition to extending the authority for this program through Massachusetts and Oregon's 1115s, which were approved in excuse me, September, CMS released a new federal framework for health-related social needs in Medicaid. And what this will enable states to do is take federal financing and specifically invest more and more broadly in housing and support housing and nutrition support services for Medicaid members. This is frankly precedent setting, and we were surprised to see this early on in the program, but I do think is demonstrative of the work that the Flexible Services Program has done, but also other states have done, namely North Carolina, Oregon, some of the others, California, to name a few, in demonstrating early ability to really start to improve outcomes, both health as well as cost, for members who receive these services. And so the Biden administration substantially expanded our authority, and beginning in April, we will be able to, provide more and more of these services to our members, which we're very excited about. One that I do want to flag, which we're particularly excited about, is what are referred to as household level nutrition support services. So the easiest way to think about this is if I'm working with one of our members in my clinic and they meet a certain set of criteria and they are eligible for nutrition support services, that's awesome. They get those nutrition support services. However, individuals do not operate in a silo. They go home to a home, which has other people around the kitchen table, and that food is oftentimes diluted among the entirety of the household. This is something that we knew going into the program in 2020. This is something that we have heard in spades from our ACOs, our stakeholders, our members, as well as our flexible services organizations, excuse me. And so with this new authority, we will now, for pregnant individuals and children, be able to provide broader nutrition support services for the household level for members who qualify. It's not in transparency as much as we asked for. We asked for household level nutrition support services for all members. CMS met us halfway. So for pregnant individuals and for children, we will be able to provide these moving forward, which we're very excited about and do think could be a substantial delta in terms of the impact that we're able to offer through this program. Contractually, what is this going to look like? And sorry, I'll speed up because I recognize we're almost running out of time. Okay, so we're going to raise the expectations for ACOs to provide these services across the board. One of the things that we've seen, as with all new programs, is some innovators take things up, some do not. And so we've seen variable uptake of the Flex program across the ecosystem. Moving forward, ACOs will be contractually mandated to serve at least 1% of their population with these services. Community supports program, very briefly, it's been in existence since 2005. It provides housing support services for some of our chronically homeless individuals. Through the 1115, we've received broadened authority, so we'll be able to provide these services to more members, broader definition, as well as more of these services, and in particular start to target some of our justice-involved individuals who are transitioning back to the community. Next slide, and we will finish up in 1 minute, I promise. CP program. We've learned a lot over the last 4 years. We're continuing to learn a lot. One of the things that we learned most clearly is that for this program to work well, ACOs and CPs need to be attached at the hip and work very closely together and feel accountable to the same things. So the big change here moving forward is that we are no longer going to be contracting directly with CPs as MassHealth. They will be material subcontractors of ACOs and MCOs, such that we are intending to and believe this will help improve that functioning partnership as well as the accountability between the CPs and their managed care entities. There's a number of other, I would say, more incremental changes to this program, but overall, we're very optimistic about the direction that this program is going and very committed to continuing to work with it. Next slide, please. Last, I will leave you with, and maybe you guys can take this home and read it with a glass of wine. It's particularly dry, but hopefully helpful. These are our 17 new ACOs that we'll be launching on April 1st. One thing to call out that we're particularly excited about, in addition to over 1.25 million members being served through value-based care, MassHealth now has every major provider system and every FQHC enrolled in the ACO program, which we see as a good sign of progress. Thank you so much.
Wow, Ryan, I'm blown away with the comprehensiveness of your presentation and the data that's coming out of it. It's teasing us in directions and encouraging us to look to directions that have some very exciting potential. So thank you so much for coming and sharing it. And thank you for you and your team to do the work. With that, I want to open it up to any questions or comments. Marty.
So just a comment, having watched this program grow over time, I just am so impressed with where you're taking it and where your team is taking it. These are huge improvements that certainly will result in better care for, some of the most vulnerable folks in the state. So congratulations. I really think this is impressive.
Thank you, Marty. Don.
Yeah, my first comment is also, wow, Ryan, this is definitely nation leading, and thanks to you and your team, and we're going to learn a lot. As you know, for your Model A, been a lot of controversy, and I've been part of it nationally about case mix adjustment gaming when there's an intermediary taking risk. Can you comment on that in the ACO program when you interpose a plan? How are we dealing with case mix adjustment, risks, severity scoring, stuff like that, and we protected against the games we're seeing nationally?
Thanks, Don. I will say two things on this. One, we very much agree, and we are very concerned about the coding wars. My practice, we recently learned, we did not ask for, but we recently learned we were the beneficiaries of a new nurse who will be providing no clinical care and will just be doing coding on all of our charts. So it is a very, very real dynamic. And I would not say that our program is immune to this. However, two things. One is that we have made the intentional and explicit decision to not release our risk adjustment model, much to the agita of the ecosystem. Everybody is asking for this left and right for exactly the reasons that you raised, because they want to know what HCPCS codes are weighted and how. So it is a black box, which is a double-edged sword, I will say. But it is, we made that decision specifically to help prevent, to whatever extent that we were able to mitigate further downstream coding wars. Two, I will say, while it doesn't stop the coding wars, MassHealth, as I think most of you are familiar with, does have one of the more progressive risk adjustment models insofar as we incorporate health-related social needs and zip codes and race to the extent that we are able to into our risk adjustment model in an effort to downweight some of what we feel are historical inadequacies in risk adjustment that are much more focused around HCPCS codes and utilization, which unintentionally actually hurt members who are the most vulnerable, who can't effectively use the healthcare system. So we've spent a lot of time focused on that, and actually we are releasing shortly a new primary care risk adjustment model, which is flowing into the subcapitation program that our colleagues, Arlene Ash in particular at UMass, has been a leader in developing. And we hope will, again, further reinforce and institutionalize throughout the risk coding more of the health-related social needs and social factors that we believe are probably more demonstrative of where we need to invest relative to some of the DXCG and the RxCG algorithms that fuel a lot of more traditional risk adjustment methods. That being said, I don't want to minimize what you're saying because it's a very real dynamic in Medicaid as well, unfortunately.
Thanks. Well, you'll be innovating there too. Could I just put in a word, if it's okay with David Seltz, that this could be an area of partnership with David Seltz, David Auerbach, and the team at in HPC. We've been really looking at this now for quite a while, and you might end up with some data and some models and some information that would help enrich our understanding of the coding wars and how to intercept them here.
We would welcome that.
That's great. Thank you. Deb.
Thank you so much. And thank you for this presentation. Really useful information and exciting outlook. Can you educate us a bit about how to think about the redetermination process and how you'll work with the ACOs over the course of the year as that takes place?
Thank you, Commissioner. And to talk about the elephant in the room, also on April 1st, Medicaid will be taking on the largest single eligibility process since Medicaid's development in 1965. So we will be redetermining. Sorry, just to step back, during the federal public health emergency, as a part of our maintenance of effort, as a part of multiple federal pieces, we have not actually churned anyone off the Medicaid rosters. Nationally, Medicaid enrollment is just shy of 92 million, and in Massachusetts, it's 2.3 million, the highest it's ever been nationally and in Massachusetts. We are working aggressively to ensure that as many of the members that we will be redetermining over the next 12 months, 14 from now, 12 from April 1st, either end up on a connector plan or through employer-sponsored insurance, some other form of coverage. Our goal is that there is a 0% delta in terms of the overall state healthcare coverage, and instead that we are able to work with all of our members as well as our health plans, stakeholders throughout the community to ensure that everybody who is deemed no longer eligible for Medicaid will end up with other coverage. What does that mean functionally? There's a few different pillars that we've been working through. One, thank you to the legislature, authorized a substantial amount of investment in this. Healthcare for All received multiple millions of dollars directly to work with us, as well as all of the managed care entities and fee-for-service providers to ensure that members are getting literally door knocking, messaging and marketing campaigns. You will start to see things actually next week. We've already released some of these materials, but you're going to start to see them on television, on radio, on Pandora and Spotify and all of the other areas that will be very targeted. That campaign will be in 12 different languages with additional translation support through a variety of mechanisms. Our ACOs and MCOs, I will say, have a vested interest in making sure that members do not churn off eligibility, which is good for us. We want to make sure that anybody who is quote unquote redetermined finds a new coverage home, whether that's through a qualified health plan on the connector or otherwise. And our ACOs and MCOs also have that same vested interest because they want to make sure that no one loses coverage and the ability to see them. And so we are working very, very closely with them. Actually, I'll be meeting with MAP later today on just this topic. And so it is very much a partnership. And I will say the good news is that in this situation, the incentives are very aligned, that everybody wants to see everybody maintained on coverage. Happy to provide additional information. There's a lot there, and we're going to be working very closely on this over the next 14 months.
Thank you, Ryan. David, did I see your hand up?
You did, but I will defer to Commissioner Singh.
Okay, Karen, your turn.
Thanks, David. Thanks, Barbara. Wonderful presentation, Ryan. Happy to take some of the further details of my question offline, but just at a very high level, around the health equity things, we want our partners to be sort of, it's already really tough, as you say, gathering this information from our members. It's sensitive. To make sure they're not sort of needing to obey multiple masters, we are looking at alignment with sort of CMS's hospital approaches down to the details of how we report race and ethnicity. Some of the new categories coming online, like Middle East and North African as a category. All the head nodding is perfect. And do we have preferred screeners for the social needs screening? Do they choose from a set, or will it be more aligned for when this data hopefully becomes universal, and we'd want it to be interchangeable, knowing that we're looking at apples and apples?
Yes, thank you, Commissioner. I think there's happy to have a lot more discussion on this because this is like hours, if not weeks. Two quick responses. One, screeners, in terms of the tool, we are not standardizing, and that's for a variety of strategic and operational reasons, which we've had a very, very difficult time issuing standardized protocols for the actual tool. And so we have, over the last 5 years, actually become more liberal in terms of the tool itself and more prescriptive in terms of what is included in the tool and however they choose to operationalize that. This is where I think actually your question is much more challenging. So a couple of points. One, for better or worse, Massachusetts is at the leading edge of this, and we do not actually have federal standards for many of the indices that we need, that we want to collect from a race, ethnicity, language, disability, sexual orientation, and gender identity perspective. And without federal standard, it is very difficult for us to choose a set of, for example, you raise MENA. Do we use Middle Eastern and North African as one of our variables, or do we choose to use something else, or do we have it at a higher level? We are in active discussions with OMB, CDC, CMS, NCQA, AHRQ to try and understand, before we have provider systems invest literally tens of millions of dollars in building out the architecture and the infrastructure and the workflows and the screeners and training staff, training call centers. We have one shot to get this right. And so we have actually intentionally slow walked some of the decisions and are putting them later in the program in an effort that hopefully we will have further guidance from some of our federal partners. That we will be able to choose an aligned set that we know CMS is going to use, for example, in some of their upcoming programs that they've already forecast. As you may be aware, they've already released a preliminary healthcare quality slate, health equity quality slate, which at this point remains preliminary. We would love if that were final prior to us making a decision as to what we're going to hold providers accountable for, because we don't want to be in a situation where CMS on the Medicare side then comes down with something different than what we've asked provider systems to invest in and build out operational capacity for. Happy to follow up more, though. It's an area of a lot of active policy work.
Thank you, Ryan, and thank you for that, what I'm going to call final question. Ryan, on behalf of the commissioners here and the staff, thank you so much for being such a fantastic resource. You've helped frame several issues for us going forward, and we look forward to continuing to partner with you as time goes by. So thank you very much. And of course, you're welcome to stay and hear the next part of our agenda, which is program updates for, guess what, our ACOs.
Thank you so much for the opportunity.
Thank you, Ryan. Okay, so Kelly, who do we go to?
I will.
Yep, go ahead, Catherine.
Yep, I'm happy to tee this up, Barbara. Thank you.
Okay.
I'll say my thanks to Ryan as well. I think there's so much complexity in standing up a program like this, and I think it's just this is a fantastic example of not being so paralyzed by complexity that you don't move forward. So congratulations to Ryan and the whole MassHealth staff who's getting ready for a big 4/1 launch and our best. Okay, so as I mentioned at the top of the meeting, we've been thinking about how to use the HPC's lever of ACO certification to continue advancing, a wide variety of our care delivery transformation priorities, and certainly health equity among them. And very much in keeping with how MassHealth is clearly pushing forward on health equity in its new ACO program, we would like to focus updates to our certification program for this year on that specific area as well. So to give you a brief status update on the certified ACOs and then take you through our new health equity requirement proposal, let me introduce our ACO certification team, Senior Manager Mike Stanek and Senior Associate Christy Helskell. Take it away, Mike and Christy.
Thank you, Catherine, and good morning, commissioners. Very happy to be here today to be able to provide an update on the Accountable Care Organization certification program and to be able to introduce my colleague, Christy Helskell, who is a Senior Policy Associate who joined the HPC last fall and is the newest member of our ACO certification team. Before I turn to Christy to kick off our discussion of our proposed updates to the certification program's health equity requirements, I want to provide a brief refresher on the ACO certification program. So if you could go to the next slide. One of the responsibilities that the HPC is charged with under Chapter 224 is developing multi-payer certification standards for ACOs in the Commonwealth. Our payer-agnostic requirements focus on core competencies of ACOs as the trailblazers of care delivery transformation. One important aim of the program is to support payment reforms across both the commercial and the public payer markets, while aligning with other ACO programs in the market, like MassHealth's. The program launched in 2017 when we issued our first two-year certifications to 17 organizations around the Commonwealth. Subsequently, we produced a series of what we call learning and dissemination products to further our aim of building knowledge and transparency about ACOs. These outputs include policy briefs and profiles of each of the ACOs. Notably, in 2021, as we prepared for the program's third certification cycle, we made our first significant updates to the certification standards. Building on what we had in place before, we evolved the standards to embrace the ACO model as a catalyst for learning and improvement among healthcare organizations, and to recognize the role that ACOs can play in advancing health equity in the Commonwealth. So in 2022 and 2023, we certified 17 ACOs under these revised standards, which are known as the Learning, Equity, and Patient-Centeredness, or LEAP criteria. Next slide, please. So here you can see a snapshot of the components of the LEAP standards. ACOs receiving recognition under the LEAP standards must meet a set of objective criteria focused on core ACO capabilities, demonstrating dedication to patient-centered care, use of evidence-based and data-driven strategies to improve care delivery, and commitment to addressing long-standing health inequities. The standards include a set of prerequisite requirements pertaining to governance, holding of risk contracts, and compliance with a variety of legal requirements. But our assessment criteria are the core of the program. These evaluate the ways that ACOs deliver patient-centered care, foster strong cultures of performance improvement, use data to facilitate better decision-making and support improvement, deploy population health management programs, and take a whole person approach that includes supporting behavioral health integration and attending to patients' health-related social needs. And as you'll hear more about in a few minutes, ACOs are also required to report on efforts to reduce a health inequity. We also include some supplemental data collection as part of the application process. This information is not evaluated, but it helps to inform our thinking about future directions for the program, as well as providing an important window on ACO activities and operations. The supplemental information topics listed here are from the most recent application. Next slide, please. I want to pause here to note 3 recent certifications under the LEAP criteria. While the first cohort of 14 ACOs was certified under LEAP about a year ago, more recently, just in the past few months, we've certified 3 additional ACOs: Berkshire Health Systems, East Boston Neighborhood Health Center, and UMass Memorial Health. Berkshire is not new to the program, but its certification this year now incorporates both a Medicare Shared Savings Program agreement in which it participates and its MassHealth ACO contract. East Boston Neighborhood Health Center is a new ACO this year, though it previously participated as part of another HPC certified ACO. And UMass also had not been previously certified and is new to our program. With these additions, we now have 17 total certified ACOs that represent over 3 million covered lives across the Commonwealth. As always, we want to congratulate and thank all of these organizations for their partnership and, most importantly, the dedication that they've shown to providing high quality, efficient healthcare to their patients. With that, I will turn to Christy to talk about our upcoming certification cycle.
Thanks, Mike, and good afternoon, commissioners. If you go to the next slide, I'll start here with giving a brief overview of the timeline that we're working towards over the next year for our upcoming application cycle that'll begin in the fall. So starting here in January and February, where we are currently, we've been having conversations with stakeholders about our proposal for the health equity requirement that we'll be discussing more in detail today. And through the rest of this month, as we work to finalize those standards, we'll then transition into moving into the spring, where we'll be updating both our online application portal as well as our guidance documents, including our platform user guide, which we refer here as the PUG. And one thing I'll note about that is that other components of the standards won't be changing, except for the health equity requirement that we'll be including guidance on in more detail in the PUG, the platform user guide. Moving into the summer, we'll host a kickoff meeting for ACOs where we'll introduce the new application requirements. And then in follow-up to that, we'll begin having Q&A opportunities such as office hours in July and August with ACOs to answer any questions that they might have in anticipation of completing their application in the fall. Beginning in September, ACOs will be able to access the online application portal and begin working on their submissions, working up until a deadline of October 1st, when all application materials will need to be finalized. And once applications are submitted, we will begin our review process in October and aim to issue all final determinations to ACOs before the end of the calendar year on December 31st. Next slide, please. This slide here shows the health equity response requirement that was completed by ACOs during our most recent application cycle in 2021 to 2022. In this application, we asked ACOs to write up a narrative response describing a single ACO activity or initiative implemented in the past 2 years to address the health inequity implemented affecting its population. The health equity response needed to include 3 key elements described here. The first being a description of health inequity that the activity or initiative aimed to address, including identification of the specific population impacted by the inequity. The second, ACOs needed to describe how they identified the health inequity, including any formal or informal data sources that they used to do so. And lastly, the ACO needed to describe what exactly the specific activity or initiative was and how it aimed to address the health inequity, including specific goals or targets for improvement. Next slide, please. So the health equity response in our last application, it was really our first foray into understanding the work that ACOs are completing to address health inequities in their populations. As a result of gathering these responses, we received many rich responses. And in reflecting on the responses that we received, we were both able to get a sense of the progress that ACOs have made so far and to identify several key areas of opportunity for future work. So here, I'll briefly walk through the 3 opportunity areas that we identified. The first, treating data collection as a means and not an end in health equity, meaning that even as ACOs continue to improve their demographic data collection capabilities that Ryan referred to earlier, they have an opportunity to think proactively about how they'll develop the processes and infrastructures for turning data insights into concrete action within their organization. The second opportunity area really centers around better understanding the problem in the patient population through meaningful engagement. This opportunity area recognizes that meaningful engagement with patients and an understanding of the communities and environments in which they live will ultimately increase the likelihood that the program is available to support them will be responsive to patients' unique needs and preferences. Lastly, thinking about embedding health equity into aspects of all ACO performance strategy, rather than thinking of health equity as a series of special projects. In reviewing the health equity responses, we found that ACOs both had an opportunity to apply an equity perspective across their portfolio, inclusive of their population health management program, and think about setting explicit equity goals across the ACO.
You can move to the next slide. So in sharing these 3 opportunity areas with ACOs, we also took some time to complete a landscape scan and found the market to be moving in a similar direction as well. We found that as it relates to data-driven interventions, the payers, including MassHealth, as Ryan mentioned earlier, and CMS through their ACO REACH program, in addition to independent organizations such as the Joint Commission and the Healthcare Payment Learning and Action Network, are increasingly setting expectations around collecting and using data to measurably reduce health disparities. In the category of patient engagement, we found frameworks that recognize the importance of equitable consumer education and the need for having a process in place to really involve patients in program design. An example here being NCQA's Health Equity Accreditation Plus program. And lastly, many organizations, including the Institute for Healthcare Improvement, have increasingly emphasized the importance of making health equity making a strategic commitment to health equity and setting explicit equity goals. And we've seen this with public payer ACOs who will begin requiring creation of strategic plans related to health equity specifically. Next slide, please. And with that, I'm going to turn it over to Mike to walk us through the proposal for the health equity requirement.
Thank you, Christy. Given everything Christy just laid out, it seemed clear to us that we have an opportunity to build on what we did last time, while aligning with a number of other organizations that are thinking about the responsibilities of healthcare organizations with respect to health equity. And so what we'd like to do for this year's certification cycle is to refocus the program's health equity requirements on the 3 opportunity areas that we had identified from our review of the 2021 and 22 ACO submissions. Our approach will be to ask about ACO progress in those 3 areas: data-driven interventions, patient engagement, and strategy. More specifically, as we'll walk through together in a moment, ACOs will be asked to use a template that we provide to report on their progress with respect to 5 discrete activities spanning those 3 opportunity areas. 4 of those activities would not have a minimum standard associated with them at this time. For this year's application, information would be collected on ACO progress via a reporting-only approach. However, 1 activity, which corresponds to the data-driven activities domain, would have a minimum standard this year, a must-pass status threshold. And that feels appropriate because there, as Ryan laid out earlier, there's a great deal of ongoing activity in this area, in line with MassHealth's health equity incentives under the new waiver, and the expectations that are now starting to come out from CMS and some commercial payers as well. For that reason, we think an expectation in this area for this year makes sense and is consistent with other signals that ACOs are receiving. This updated set of requirements for health equity related reporting will allow us to take a more longitudinal approach to understanding ACO progress on key areas. And that's because we will collect this information over multiple certification cycles in the coming years. And our intent, as you will see, is to position the program to gradually raise the bar for ACOs over time. Next slide, please. So now we'll walk through the 5 ACO activities that would appear in our data collection template. The first activity ACOs will be asked to report on is using race, ethnicity, language, and/or disability, RELD data, to monitor disparities and inform the development of interventions to address them. We know there's a great deal of energy in this area right now as healthcare organizations are making investments in their data collection infrastructure. Groups like the Quality Measure Alignment Task Force here in Massachusetts are working to build consensus on standards for RELD data collection, and payers are starting to put dollars in this area. Given that, it does feel appropriate to set a minimum standard or a threshold expectation for ACOs this year. For this coming certification cycle, we would propose to put that standard at disparities monitoring, that is, starting to stratify metrics to identify disparities. What we'll ask ACOs to do is report to us on their current status on this activity. First, they will characterize their current status using a structured dropdown, and you can see those structured response options here. These are meant to represent a continuum of progress that progresses from robust RELD data collection to leveraging that data to identify and monitor disparities, to designing and implementing interventions to address the disparities that are identified, and finally, a stage of iteration and ongoing improvement of such interventions. In addition to asking ACOs to characterize their current status on that spectrum, we'll ask that that they provide additional narrative on what they've been working on in the past year or two. And then we would additionally ask them to share some information on what commitments they're making or what they expect to achieve in the next year or two. And this reporting structure will look the same for each of the 5 activities that we're going to talk about today. Now, I should note here that there will be important detail to be spelled out in our application requirements and platform user guide, or PUG document, including definitions and more detail around what each of these structured status options designates. As Christy mentioned, we'll be drafting those updates to the PUG in the coming weeks. And as we note here, our information collection would be more expansive than in the prior certification cycle. Whereas in 2021 and 2022, ACOs were able to report on health equity focused efforts within a single component ACO. This year, we'll ask ACOs to provide responses across all of their component ACOs. As a reminder, in our certification program, component ACOs are any separate risk contracting entities with unique governance structures within the larger organization. An organization might have different component ACOs that manage Medicare versus commercial versus MassHealth risk contracts. And so this reporting would apply to each of them. Next slide, please. The second activity falls under the patient engagement opportunity area. As ACOs are working to develop interventions to close disparities and improve health equity, this activity reflects the degree to which the patients ACOs are trying to serve have a voice in that process. So here we're thinking specifically about folks impacted by a health disparity or a health inequity that the ACO is targeting. The status scale here reflects a modified version of a community engagement scale that is used by the Department of Public Health and others. Ascending that scale entails sharing information with those patients, then actively soliciting and incorporating feedback to inform program design, and finally offering patients the opportunity to help lead or guide development of such interventions. Next slide, please. Now, the final 3 activities all pertain to the strategy opportunity area. These activities are intended to gauge whether ACOs are making organization-level commitments to health equity, and whether they're starting to apply a health equity lens broadly to the work or the operations of the ACO. The structured status options for these activities are less of a scale and tend to be more binary yes/no options. So one thing we'd like to ask, as you can see here, is whether the ACO has made any explicit commitments to advancing health equity in its strategic plans, and whether it has set any explicit goals in this area as an organization. Next slide, please. This activity focuses on any changes to internal financial incentives that ACOs have made to support any health equity related strategic goals or targets. We're always interested in the tools and the approaches that ACOs use to impact care delivery and achieve their goals. Here, we would be looking to understand if ACOs have developed any incentives to support any strategic objectives around improving health equity. Next slide, please. Lastly, we have an activity focusing on the degree to which ACOs are operationalizing or implementing any health equity components of strategic plans. Essentially, we're seeking to understand here the degree to which ACOs are applying a health equity lens to any of their activities and operations. Our intent here is to hone in on actions and changes that ACOs are putting into practice. And this activity could take a great many forms in practice, from devotion of budgetary resources to dedicated staffing to workforce development and training and more. So this will be an important area to watch develop over time. Next slide, please. As you know, commissioners, anytime we are contemplating changes to the ACO certification program, we think it's very important to get some perspectives from the program stakeholders and those with interest in the issues that we're tackling. Over the past several weeks, we've been engaged in some conversations, including with certified ACOs, on the framework that we've presented today. And we wanted to give you a summary of what we've been hearing. First, we've heard a great deal of validation of this framework and our overall approach. Stakeholders feel that we have identified the right priority areas to focus on, and they appreciate a longitudinal approach that signals some expectations for the direction of ACO progress over time. Second, in that same vein, stakeholders supported our approach to combining data collection with escalating expectations for progress on advancing health equity over time. Third, as we had expected based on our review of the landscape and our research into the work other organizations have been doing to guide the conversation on health equity, stakeholders indicated that our framework is consistent with other signals in the market. We were happy to hear that folks generally perceive this approach as being in alignment with others, including MassHealth. And lastly, we were able to confirm our sense that ACOs are further along in the data-driven interventions opportunity than on the patient engagement and strategy opportunities. This helped to validate our approach of setting a minimum standard only for the data-driven interventions activity this year. And it also suggests there may be opportunities for the HPC to support ACOs in making progress in the other two areas in the future. We really appreciate those organizations and folks who took the time to talk with us. And overall, we've come away from those conversations confident that the approach we've laid out today is the right one. Next slide, please. With that, commissioners, I'll open the floor for any questions, comments, or feedback you might have on any of this. You can see we've offered up some potential questions for discussion, but really any feedback, regardless of whether it pertains to these particular questions, would be very much appreciated. So thank you.
Thank you, Mike and Christy, for a fantastic presentation of the next stage of our ACO development. So with that, let's open it up. Are there questions? It's a lot to digest. Don.
Yeah, thanks for that. Wonderful, Mike, just wonderful. I may have missed it. You hit a lot in your presentation, but one of the incentives I'd love to see in this ACO program is citizenship in a collective action in Massachusetts for learning from the experience of each of the ACOs. So I'd love to give ACOs points for becoming part of a learning community in which the Commonwealth is learning better and better how to deal with these issues. Actually, an active incentive to participate in developing a learning community in the state.
Thank you, Don. That's an interesting and exciting idea. Any thoughts or comments from the rest of the committee or from staff? All right, then, Marty.
I mean, I think this is an important step. I think it's logical in the evolution. I guess my question is, why not go deeper faster? So, there's really only one piece of the standard here that is required. You sort of share with me your rationale for not going deeper.
Sure. Yeah. In our conversations with folks, it was clear that there's a lot of opportunity, particularly, as I mentioned, in the patient engagement and the strategy components of this, for everybody to kind of grow together. I think there's a sense, and to Commissioner Berwick's point, I think there are some opportunities here for collaboration and potentially convening ACOs to really move the needle on some of these things. And, candidly, we don't want to get too far ahead of where the current state is. We're hoping to be able to chart out sort of a path over the next couple of years and use the certification standards to really help to move the ACOs in a given direction. And so, we view this as kind of a starting point, but the intent is really to escalate over time and be able to, move everybody along at a reasonable pace.
Thank you, Mike. Marty, you okay? Any follow-up?
Good.
Okay, thank you. Other questions or comments? Well, pardon me. I'd just like to say, and sorry to go back on screen because I know I'm going to irritate you with my lack of clarity on the screen here, but I'm excited about the work on equity especially. And I'm excited to hear that the ACOs are very responsive to it. The commission made a very strong commitment in the last couple of years that we were going to focus with great intent and great intention on the issues around equity. And this is demonstrating in a very concrete and measurable way that we're doing that. And I congratulate the staff for the insight as to how to move that in that direction. And to swing behind Marty, I'm looking forward to as we continue to develop a higher level of sophistication, and we know that the ACOs can move with us, that we move more quickly down the road. Look forward to being able to do that. So with that, are there any other questions? Kelly or Catherine, have I left out anything that you need us to do? Okay, then, we have a series of upcoming meetings that I hope are going to be up on the screen, or Colleen is going to tell us. I'm not sure which. There you go.
Yes, absolutely. So coming up next, inviting you all and everyone to our annual hearing on the healthcare cost growth benchmark. That's happening on March 15th. This hearing, as you know, we're going to solicit and receive testimony on setting the benchmark for next year. So we're talking about the 2024 benchmark. This is the fundamental mechanism for the state's cost containment efforts. We're co-hosting with the legislature's healthcare financing committee, and we're asking everyone to pre-sign up. We've already had a ton of pre-sign up. So please contact us, contact Ash Conter at the HPC if you have any questions. And if you want to sign up, we also will accept written testimony as well if you're not able to testify in person. And then on the next slide, yes, save the date special event coming up 2 weeks after that, March 29th. This is on healthcare workforce in Massachusetts, building a robust healthcare workforce. We'll be releasing a report that date. More to come on this. Definitely going to be an in-person event for sure. We'll have a lot of special guests. Our board will be there. So excited for everyone to attend that. And that's it for next events. I think on the next slide, the next meeting of the Care Delivery Transformation Committee and the MOAT Committee will be back to back again on May 10th. Coming up sooner than you think, actually. So that's it from me on updates, Madam Chair. Sending it back to you to adjourn us.
Oh, thank you. That's the